Let me know, Joe, when you think everything's running properly.
Yeah, the recording started.
Okay, right. We'll make a start then if everyone's ready. Good morning and welcome to the governing body meeting of Ipswich and East Suffolk CCG, which is being held in public. As you can probably realise, Mark's got other duties elsewhere this morning, so he's asked me to fill in for him. And that's the same with Richard Watson as well. He's sent his apologies, and so Eugene's filling in for him this morning, who's more than capable. If any members of the public who are watching need to submit a question, they can do that via the live chat function within the app. And we've also received some questions prior to the meeting. So that's the bit of admin I had to do. So if we just go straight into the agenda then. And Joe, apologies.
The apologies I received were from Badri, Mark Shenton, Richard Watson.
Okay, great. Thanks very much. Any declarations of interest? No. Hospitality and gifts. That's really just a reminder to say, if you have, fill in the register. Okay. Minutes of the previous meeting. We'll take those as a whole. Everyone happy with those? Maddie's shaking her head, so I'll go her word on it. Any matters arising not picked up in the minutes or not on the action log? No. Okay, thank you. And then action log. There's only 3 items on there. Is everyone happy with the first one? We've had an update on the 13th to the 5th. That's regarding the staff survey. Did you want to say anything about that, Amanda?
Sorry, I couldn't come off mute there, Graham. I don't think so. The only thing that I would want to add is that we're continuing to work with our staff on a compelling action plan, which is going to our remuneration committee that will oversee our progress as we move forward. So nothing further to add, Chair. Thank you.
Great. Thanks, Amanda. The second item, it was a question from Mr. Squirrel, and I think that he's been responded to, so that's complete, so we can take that off. Are you happy with that, Lisa, to take that off?
Yes, thank you. Thanks.
Okay, and then the final one is again another public question, and I believe Richard has responded to that as well. So we'll take that off at this time. Okay, moving on. Ed, general update, thanks.
Thank you, Chair. Morning, everyone. So I have 3 updates, but before I do, I just want to say how fantastic it is to see the papers relating to mental health transformation on the agenda. That's something that's an absolute priority for us and our communities. I know there's a huge amount of work that's gone in from a large group of people to get us to this point. So I'm really pleased about it, and also to see how the proposals are looking to work with the voluntary sector in a sustainable way in the future. So that's fantastic. So 3 kind of main obvious updates is the vaccination programme continues to power forward in Ipswich and East Suffolk. We have now reached over half of the adult population with 2 doses. So we're rapidly protecting our population. We have done over 1 million jabs as of Friday as a system. And if we look in our 3 hospitals in our ICS, including Ipswich Hospital, there were 0 COVID inpatients yesterday. So all of the work, I think, is to protect the communities is having an impact, which is great. The challenge now is the rollout to the younger cohorts, and there seems to be more difficulty in getting the same volume, so younger cohorts coming through for the vaccine. So we're having to rethink our approach and work out how we secure their support for this next phase of the programme. But all in all, I think we're making excellent progress. And if you look at a local authority level, East Suffolk Council and Mid Suffolk Council are consistently the top 2 local authority areas in the country in terms of progress. We've got some greater challenges in Ipswich, particularly some of the very deprived wards. We're working out how we can do some really targeted work in some of those areas, and the bus we've got has been really helpful in that respect. So thanks to everyone for their work on the vaccination programme. We're doing a huge amount of work in terms of the recovery of our services, and we've been selected to be a national accelerator site for the recovery of elective care services in our physical acute trust. So we will be accelerating quicker than many areas of the country in terms of that process, and we'll be sharing our learning across the country as we go. So it's a great tribute, I think, to everyone's efforts that we've been given the status and indeed funding to move forward at an accelerated pace. And then finally, I just wanted to say we've got a very exciting week in terms of integrated care. We've got the foundation week of our Integrated Care Academy, which the CCG has helped to create and support. And there are a number of events, online events taking place during the week. It's been very well advertised, and I think we've got well over 600 people supporting those events. So it's really exciting to see something that started as an idea materialise into reality, and it's a great foundation week. And the whole purpose is really to think about how we reform the delivery of care through education, and really developing people at source and creating opportunities, particularly for young people in Suffolk to go into health and care roles. So it's a really brilliant innovation, and thanks to people involved, particularly Mark, who's taking a leading role as a professor at the university. That's where I was going to stop, Graham, but very happy to take questions.
Okay, thanks very much, Ed. Any questions, Fred, on any of that? No. Okay. I was going to say, Ed, I mean, that's 3 really fantastic pieces of work there, isn't it, in terms of what the CCG is doing. And, you know, when you just speak about it quickly, it doesn't sort of genuinely reflect the amount of work and effort that people are actually putting into these programs. And, you know, it will have payoffs, you know, further down the line. So thanks to everyone who does that work. Okay, if there's no more questions for Ed, we'll move on then to the patient story. And I understand we have Carl and Sasha with us today, and they are both users of the personality disorder service, and also they helped us co-produce the personality disorder business case, which is further on the agenda today. So we thank you both for your time today and the time that you've put in before this, helping us co-produce the business plan. So that's appreciated. I will just now hand over to Eugene so he can introduce you properly and sort of set the background to this. So, Eugene.
Excuse me. Thank you, Chair, and good morning, everybody. We're delighted that Carl and Sasha are joining us this morning. Their stories are that of users with experience and here to help us identify the gap that we have for supporting personality disorders in the Suffolk system. As you said, Chair, they have worked as part of the PD working group led by Dr. Lulu Preston, who's also with us this morning, to develop the business case, which is part of our mental health item, which will come a bit further down the agenda this morning. As I said, I think this is a really strong and moving piece of work. So without further ado, if I could pass over to Carl and Sasha to take us through their story.
I think Sasha's going to go first, aren't you, Sasha?
Yep, just unmuting myself.
Okay.
And before I begin, I'd quickly like to say that being a part of the personality disorder and complex needs pathway has been a complete privilege. Before joining the team, I thought I knew what co-production was, but I really didn't. I've never seen professionals and service users working together so equally, so genuinely, or so excitedly before. And I've never been prouder of a piece of work or more hopeful for the future of mental health services. So I wanted to say thank you for being a part of it. And now I'm just trying to figure out how to communicate to all of you the transformative power of the pathway. And I think the best way to do that is to share some of my story, stopping to reflect on how my journey could have been made quicker, easier, and so much less painful if the pathway had existed when I first became ill. So I'm going to rewind to little 14-year-old Sash. 14-year-old Sash, who, despite having an amazing family, amazing friends, and an abundance of hobbies, was thoroughly miserable. She'd been self-harming for 2 years, secretly longing for help, but telling nobody. And when she finally did gain the courage to ask for help, she was denied it. Apparently, I was not ill enough for CAMHS, and I was too risky for wellbeing services. In fact, I was actually rejected from CAMHS 4 times in total, the words "not ill enough" ever present in my mind. Not ill enough? How humiliating. I'd have to do better. It was only at 15, after a near-fatal suicide attempt, that CAMHS finally accepted my referral and shoved it on the 9-month waiting list, during which time I deteriorated rapidly and was sectioned to a CAMHS hospital against my will. This needn't have been the case, and if the PD pathway had existed when I first made contact with mental health services, I really don't think that it would have been, because the PD pathway knows that when someone asks for help, that the only correct answer is yes. At 14, I was desperate to stop self-harming. I wanted to stop, but I just didn't know how to. I needed help, someone to listen, someone to care, someone to advise. I wasn't asking for a care coordinator, a family therapist, an intensive course of therapy, just a few coping skills and a few kind words. And the pathway provides different levels of care suitable for all needs, regardless of risk. They recognise that ill enough does not exist, that people don't matter because they suffer, and that risk is not a measure of illness. I think that if the pathway had been there to support teenage me, I'd have known those things too, and my desire to recover just would not have been replaced by the need to get sicker. And so much pain and trauma would have been avoided as a result. So most of this trauma and loss came from my inpatient admission. My admission, which, as I previously stressed, it was totally avoidable. I spent nearly 2 years locked up, far away from the friends and the family who inspired me to get better. 2 years without school, 2 years without fresh air, 1 year without therapy, 1 year without medication, and almost every minute of it traumatic. I saw and experienced things that no young person, well, really actually no person, should have to see or experience. Found friends, blue-faced, barely breathing, heard shrieks so animalistic and so raw that I can never unhear them, being stripped naked, transported in cages, handcuffed to nurses, brutally injected, sexually abused, aggressively tubed. Once I was locked in a seclusion room for weeks and fed through a hatch in the door, left in a bare room, distressed, alone and only a child. I think for me the worst part is that these things never leave you. I still, even though I am thriving now and have got the support I need, I still feel sick every time a song or a face or a scent reminds me of hospital. I still wonder which of my friends is dying every time an alarm sounds. Still wish I'd been sicker than I was. And I still grieve for my younger self, the self who had her childhood stolen so violently, who missed A-levels, prom, school trips, family holidays, first words, last words. I can't really articulate the profoundness of these losses, of the pain that I feel every time my amazing little brother says he doesn't miss me when I'm at uni because he had to get used to not having me around. The pain that I feel every time I can't join in a conversation with my peers about the nostalgic teenage years. The pain I feel every time I receive a phone call to say that another of my friends has passed away. And why do I tell you all of this? Because it didn't need to happen, and with the PD pathway, it absolutely won't. The pathway believes in short, meaningful admissions. People won't be tossed into hospital and left there indefinitely, left there until every millimetre of hope's been drained from their body. The day a patient arrives on the ward will be the day that they start working towards discharge, and as a direct consequence, so much trauma and so much loss will be avoided. The benefits of the pathway just can't be overestimated. So before I finish, I'd also like to say that in spite of the pain mental health services caused me, I also met some of the most amazing people, both staff and patients. Then there are nurses, healthcare assistants, cooks, cleaners, therapists, doctors, all of whom their extraordinary words will stay with me forever. And I know, and I really do know, that these staff members want an exceptional service every bit as much as we service users do. And I think that the pathway is evidence of this. And on that note, I'll pass you over to Father Carl, who is the single most brilliant person that mental health services have introduced me to.
Thank you, Sasha.
Thank you so much, Sasha. Absolutely marvellous as always, and I'm always left feeling a bit sort of need to gather myself together after listening to your story, because I fully understand what you've gone through, because I've been there myself. So anyway, hi, I'm Carl, and I'm Sasha's somewhat older counterpart, just in case nobody's noticed yet. And anyone who knows me, and I'm sure Eugene would agree to this, that I really tell my story in public, but I feel this pathway deserves it. So I became ill at the age of 11 years of age, due to constant exposure to extreme life-threatening traumas. I think they call them ACEs, adverse childhood events. And that was basically an hour-by-hour experience I was having at that age. These experiences prove, I won't go into the details, but they proved devastating in my adulthood, to the point that they caused me to lose my business, my home, very nearly my own life. But losing a business and a home really pales into insignificance compared to losing your family, and losing lots of years to a condition that nobody, including myself, understood or even realised existed at one time. So I did some rough calculations. From the age of 11 to now, on average, I reckon I've lost 3 months every year of my life since I was 11. When you think I'm now 60, that's 12 years of my life that I will never, ever get back. And maybe that's why I only look 50, because I've lost 10 years or more. And so I look a lot younger than I probably am. And I'm definitely more childish than I probably look. The cultural belief of personality disorder was, as I said, that it was sort of finite, not worth the effort of trying to improve somebody's life who was suffering from personality disorder. There was lots of terms bandied about attention seeking, etc., etc. And this sort of thing, once I got my diagnosis and decided I was going to have a life worth living, meant that I could not accept this finite diagnosis. And that drove me forward to challenge and disprove the thinking. So as you can imagine, my delight when I met Lulu 4.5 years ago and got to start working or co-producing together the PD pathway strategy, and watching our team develop to what it is today, especially having Sasha on board, has made a massive, huge difference, because we don't want an old man's sort of perspective on this. We need a broad perspective on what it's like to be an older person and a young person with a personality disorder. So what we've done, I think, is we've proven that, yes, we can upskill staff quite easily by providing training, and as Sasha said, for the patient, meaningful, purposeful admissions, short admissions, and through the training we can make it more accessible to therapies such as dialectical behavioural therapy and CBT, etc., etc. And And by upskilling people, we'll make these therapies more easily accessible. And that way we'll speed up the point of which somebody begins their journey with personality disorder and how quick we can address it before it becomes a complete crisis. And to quote Sasha again, we shouldn't have to get ill enough to receive some sort of treatment. And that's part of the reason we designed the needs typing, so your needs can be addressed rather than the actual diagnosis. So yes, you can have a personality disorder or not have a personality disorder, but it's your needs that need addressing. So if at the time you for instance, for me, I have a diagnosis of personality disorder. It's an overarching diagnosis. It doesn't exclude me from having depression or anxiety as well. So through needs typing, I can have those things met rather than just say it's just your PD playing up. So yeah, that's what's in it for us patients. What's in it for our trust is what I always think, and what's in it for our CCGs. And I think what we're going to see is a better level of staff morale, because this will be something we'll all succeed at together as a team. It won't just be patients, it will be staff. It will be our trust as a whole. It will be our CCG. And I think we'll have a sense of pride that we acted together and made this a life worth living for everyone. And I also think the most important thing is that this is something we can proudly celebrate together. Thank you so much.
Thank you, Carl and Sasha. Both of your stories were really powerful. I'm not used to having close contact with patients, so I'm probably slightly more affected than, you know, the people that deal with these sort of issues every day, but it was very powerful. And I'm really sorry that you had to suffer as you did. That should have never happened. And I'd just like to ask Lulu, could she say a few words at this stage to get the mental health trust position on this?
Thank you, Chair. Thank you, Carl and Sasha, as always. Chair, you mentioned that you are not normally hearing stories like this, so you're perhaps more moved. I can tell you I've known Carl for at least 4.5 years, and I moved every time. So, which is one of the crucial powers of co-production, that when we are working with people who are using the services, not only does it help us keep the point of what we're doing front and center, it also makes the work much more comprehensive, much more relevant, stops us, I guess, typically in healthcare, not just mental health care, you know, we've scratched our heads and thought, how can we do this better? We're on a cusp now, on a kind of a shift really in our culture to think, well, actually, let's not sit in a room somewhere and work out that answer ourselves. We're going to work with, and continue to develop services together, continuously refining them, work out what's working, how we're meeting that need, how we can do it better, but in that partnership style, not kind of attacking each other or getting cross, pointing fingers across the service user clinician divide or the, you know, mental health trust CCG divide. All of that stuff is just interfering in the point that we're all coming to work for, right? So just I don't know how much more there is to add to what Carl and Sasha have said, but from a more formal way, I just want to say that we understand that there is need that we have not met, and this is true for all mental health trusts in the country. And we are working on creating these tiered pathways of care that Carl and Sasha just spoke about, where if you're presenting to your GP has had, and the practice nurses or the mental health link workers in that practice have had some training in our needs typing screening that Carl mentioned, which doesn't displace or replace diagnosis, but it complements it and helps us while we're working out what actually the diagnostic kind of issue is. What do you need right now, and how can we meet it? We're training staff up, and we're co-producing interventions that will be based on psychological therapy that can be delivered into primary mental health care. So GPs can say, oh yeah, actually there's a group that starts on Tuesday, do you want to go? If you're really not into groups, would you like to book some one-to-one sessions for a short period of time to help skill you up? Just like Sasha said, someone who's kind, someone who understands and has got some coping strategies. If someone needs to go into secondary mental health care, again, there's going to be tiered interventions so that you can do something really intensive. We're skilling staff up and recruiting more staff to deliver a very well evidence-based, highly effective treatment, dialectical behaviour therapy that Carl spoke about, and mentalisation-based treatments that last a chunk of time. They last months, sometimes up to 12 months. Sometimes a bit longer, but actually when you think about all the life experience that you're helping somebody rebalance and adjust to and learn to move away from, it's not that much time. It's worth it. It's worth that trade-off. To skill staff up, we need people to understand things that they don't currently understand, and we need them to have techniques they don't naturally have as part of their general training. A mental health nurse currently in a 3-year degree gets 1 afternoon on personality disorder. When actually in terms of our mental health population, we're talking at about 30% of our community caseloads, 50 to 75% of our inpatient work. So there's a real imbalance between what we're here to do and what we're skilled up to do. So the pathway is much more than a training program, but it clearly has a strong educational component to it too, because of the gap I've just described. So in summary, it's training for staff, it's recruiting additional staff. We're using a kind of pyramid structure of training. So there's a foundation training for everybody, not just in mental health, but in primary care, in the voluntary care sector, agencies as well. We're reaching out to those networks to help skill up and partner with them too. And then there will be more specialised treatments for selected members of staff to deliver these interventions that will absolutely make a difference. So we're intervening earlier and intervening more intensively, using complementary models of diagnosis like needs typing, which are more agile and help us organise our care better. And we're going to make inpatient stays, just like Sasha was saying, short, purposeful and therapeutic.
Okay, thanks, Lulu, for that. It's really encouraging what you're saying there. I can tell by the detail that you're going into that you've sort of starting to get a real grip on this now, and you're actually going to move it forward, which, you know, we haven't probably done in the past properly. So, Eugene?
Thank you, Chair. I can tell by the response of the group just how moved everybody is and how fortunate and lucky we are to have heard what we have this morning. Lulu and the team have set the bar for co-production, and this is essentially how we must be working with all of our projects going forward. So a big thank you for the courage to come and speak as they have done. I've heard the story a number of times and I'm moved every time I listen. Chair, what I was going to say is that Lulu has seamlessly segued into describing the business case that's part of the mental health item. So if you're agreeable, I think let's just finish that conversation now, so that it flows. Just to add, in terms of what Lulu was saying, personality disorder was identified as a local priority within our needs assessment in our 10-year mental health and emotional wellbeing strategy in East and West Suffolk, and is also part of a national priority in our community transformation plan. So we have funding set aside specifically to address and support the development of personality disorder services going forward. I think if I could just ask you, Lulu, just to set out, in addition to what you said already, just some of the key messages, and then we can move to agree the business case, hopefully.
Thanks, Eugene. So, yeah, we're coming to Suffolk with a proof of concept, if you like, because we began this work. We had an early adopter site that was funded by the CCG in Norwich. So we have practice-based evidence to know that this works locally. In terms of how the content of the pathway has been formed, we've drawn from NICE guidance. We've drawn from national bodies like the National Institute of Mental Health for England. we've contacted NHS trusts and private healthcare providers across the country who've achieved this already, to find out what they did, what models they used, the problems they encountered, how they solved them. And we've looked at the research evidence as well as Canvas very broadly, service users and carers and voluntary care sector opinion, as well as our own clinical staff. How we've formed this, therefore, has gone is a kind of wide evidence trail of local knowledge, local input, as well as national and evidence input. We will continue that stance. It's a quality improvement model. We're going to continue that as we develop and implement. So what the plans that we have formed are likely to be effective, and we've got this local knowledge from Norwich already. However, we're going to continue to evaluate, continue to review and adjust as the kind of data informs us and as the service user and carer feedback informs us. So we're beginning with, as I said, a training program for nearly all staff, as well as very specifically this DBT training, and we're lining up dates for July and September. We're planning a recruitment program. We want to increase our peer support workforce, and so that we've got more representation within our clinical staffing group of people with lived experience. We also need to increase our psychological therapy provision. So NSFT has actually got under the kind of average of psychological provision. So we need to address that gap as well as clearly attending to medical and nursing staffing input as well. So we're going to begin, and as we kind of roll out, we're going to evaluate what we do and see how much more we can do, how much more we may need to support that work, as well as I said, providing a steady evidence base to make sure that we're doing what we set out to do. I can present the slides if that's useful, Eugene. I'm going to take your steer on that.
I think just the headlines, which essentially, I don't think there's a need for that for today's session. Thank you, Lulu. The ask of the CCG is to support the business case, which is effectively a full year effect of 483k, which the Ipswich and East Suffolk CCG share off is £316,000. The papers included the full detail of the service and the pathway. So I think it's really just to say if we can have agreement from the board, and then I can move on with the broader other items within the mental health section.
Yeah. Eugene, thanks. I'm just going to open this paper to questions. I've got a couple myself, but rather than me sort of start, I'm getting sick of hearing my own voice already. So I'll open it up and we see if we got any questions on the paper. Imran, did I see your hand?
Yeah, thank you, Graham. I think the paper speaks for itself. I've got a question for Lulu, really, Lulu. What do you think is the biggest risk in the new model, as in, implementing it? Are we talking, is it staff, is it the wider engagement of the system? Where do you think the biggest problems lie, and where do you think we need to be most mindful implementing this?
Thanks, Imran. So I know that recruitment can be a challenge. What other trusts have encountered, and actually we encountered in Norwich, is that when people are recruited to do something of this nature, because the training package is attractive and because it is highly purposeful and quite well known, we've been successful at recruitment. So just to give you an example, we managed to recruit 6 full-time band 6 nurses when we know there's a national shortage of nursing during COVID. So over MS Teams, we managed to recruit those staff into the trust. So I think there remains a risk in that area because there is a shortage of staff, but I think we're slightly ahead of the curve because of what we're offering in terms of that post. I think the biggest risk, as with many things, is that when you're trying to sort of change how the train is working, as it were, or change direction, it's not like we can stop and just realign all the carriages and then start again. We're trying to kind of change as the train is still moving. So I think it's the prioritizing the time, trying to help people understand the competing priorities and where this fits in. We've noticed that over the 4.5 years, so it's something Carl and Sasha and I are familiar with and are learning continuously about how to support our kind of internal colleagues in NSFT and in across the wider system, understand this and see how it fits with what they're already doing. So I think having an agile methodology where we're pushing on the doors that open the easiest and working out what lands first to give people a local proof of concept has been quite an effective model. So we're likely to continue in that way. But time is not our friend. So equally, we don't want a revolution, we want evolution. So I think it will take longer than we want it to. And yet, if that provides sustainable change, it's worth it.
Thank you, Lily. It's just very mindful of when we've done things in the past where we've had a huge unmet need that we haven't been managing, and we maybe have underestimated the level of demand that's sitting out there in primary care and other areas. And you mentioned lots of stats around, inpatient and outpatient and within the trust. I think, I think as GPs we recognise in primary care there's a huge amount of unmet need around the PD service, not to mention our prison populations as well, which we know are struggling as well. So I think there's a raft, and we're just being mindful of that. So, the service doesn't fall flat on its face after 3 weeks because of the demands. It's just something we've got to really bear in mind.
I think it's a good point. And if I may just clarify this is why we're delivering it within kind of broader mental health service delivery. The risk of having a sort of specialist service where people are referred into is that, just as you say, then the backlog is huge. And what we've seen other places across the country having to do is raise their threshold for entry, which means that you provide an intact service, but actually the wider need is not met. As Sasha said, actually, complexity and risk don't necessarily equate to intensivity of treatment. A lot of people need to understand what's going on for them and have a few tips on what to do differently, and they can make extraordinary changes in their functioning. So I'm not underestimating the size of the need, but I think we can be much more creative, much more hopeful about how we can meet it than perhaps mental health services have typically been.
Thank you. Aisha?
Thank you, Graham, and thank you, Sasha and Carl, for sharing such powerful stories and very moving. I think it's just a welcome move from for the primary care point of view, because this investment and knowing that there's a service out there where our patient can be supported other than just through primary care. And I think we would really appreciate that. So thank you for working on this project. And hopefully we'll reap the fruit in a few years' time when we'll be able to support everyone from very early on rather than waiting by the time they turn 50 and 60. So I think it's really positive. So thank you for all the hard work.
Thank you. Lalu?
Really, just to echo, at the risk of sounding repetitive, what everybody else is saying, your stories are so powerful. And I really just want to thank you both for one, sharing your stories, but also just working so hard with Lulu and the rest of the team on getting us to a point where we have a service that will serve. And like Aisha said, there's so much need. And Imran's also said, that I think we probably will, some of it might become more evident as the service launches. But it's just it's such a big part of what we do, and early intervention and even prevention. Talking about ACEs, like you mentioned, Carl, we know that people who've gone through ACEs, if you've had 4 to 5 ACEs, you're at high risk of developing not just mental ill health, but also physical ill health, and your life expectancy is shorter. So knowing that actually this is a start, we can start to think of actually how can we prevent some of these things? How can we build resilience into children so that they can get, we can, whether that would prevent or at least reduce the morbidity of the mental ill health that they end up suffering. I really liked what I think, and I might not have written it down right, that you said, Sasha, risk is not equal to illness. And I think that's going to take a mindset shift in not just primary care staff, but mental health care, secondary care staff, because that's how we've been trained. That's how you get into the, you get jump the hoops to get into the system is based on risk. It's all based on risk. And I think relearning that actually we can find that there is a way to support people from early on that doesn't have anything to do with risk, but it's everything to do with what they need. And that, and I have really high hopes for this system. Thank you so much for working hard on it.
Thank you, Lalu. Fanwell?
Thank you, Chair, and thank you, Lulu and the team who have worked on this. I won't repeat what others have said, but I think the thing that really stands out for me is we've been talking a lot about co-production, particularly during this time. And for some of us who have been presenting to different groups, with Healthwatch, Suffolk and others, we've seen that there is, across the system, a hesitation of actually implementing true co-production because it's stepping outside of what people are used to, and some people are hesitant. But I think you are evidencing that it is possible to do true co-production. And I think the thing that was very clear is it's not just the initial consultation that you've done with people, but the continuous sort of learning and talking to people, because you can only talk to a number of people sort of on the onset, but then, you need to capture the wider views as you go on to implement. Now, that is going to be very hard, but it's important that you've, started the journey. Suppose the point that I want to make is the thing that is going to be critical, not just for that service, but for the system as a whole, is how we capture what's working and what's not working and share it across the system, particularly for those who are still hesitant about taking on co-production. I think it would be very useful if we could take everyone on that journey with us. But thank you very much for the work you have done on this.
Thank you, Fanwell. Dean?
Yes, just quickly, because Fanwell has essentially covered a lot of the points I'm thinking about. We have sort of two powerful stories separated by decades, which tell us that the system has not been serving for quite some time, which means that there's cultural things to shift and that sort of thing. And I guess my question is around the staying true to true co-production, in that at the start of these processes, we usually concentrate on the why, the when, the how much, when in actual fact, true co-production tends to fall down on the how, on that plan, do, study, act model. We are quite good at the P part of it, the planning and the PowerPoint presentation, and also sometimes the pounds. What we sometimes are not good at, which is why we have two stories separated by decades, is how do we ensure, how do we know it's working? How do we remain accountable to firstly patients, but also system partners in that do, study and act part, so that we don't raise the hopes of our partners and patients during the initial part of co-production, but then unfortunately disappoint because we haven't gotten out of our silos and our cultures and truly engaged in fixing the bumps in the road that will inevitably come because this has been broken for so long.
If I may respond, Dean, I don't know if it was a question for me, but I just want to clear up the term co-production is used a lot, and I think people mean different things by it. What we mean by it is that when I first put my hand up to lead on this piece of work, there was no time dedicated to it and there was no resource. So I looked around to people I knew and said, can I have some help? Who wants to help? And Carl put his hand up and I said, great. So Carl and I have been the only two people doing this continuously for 4.5 years. Other people have joined and left, but it's so every working group, every kind of meeting, every planning meeting, every decision, workshops we've hosted, presentations we've done, that's been together. So we're not joined at the hip. We can move independently, but it's not about clinicians have an idea, check it out with service users. That's not co-production. That's runs the risk of being a tokenistic consultation. Co-production is everybody, all the partners sitting around the table, service users included, working out together. So what are we going to do? We've got different pockets of expertise. Let's harness them together, and that's your working group. So our PD implementation team in NSFT is Sasha, Carl, myself, our evaluation lead, who's working at that more quantitative side as well as that qualitative side of how do we measure what we're doing, how do we make sure we're doing it correctly, and our project support officer and manager. So it is, yeah, we're kind of, what's that, 2/3? No, a third lived experience, and that's continuous, and that will remain continuous.
Lulu, could I just add to that as well? I think you, Sasha, and I sort of designed the bite-sized courses and led on that as service users and delivered it to first response teams, etc. And also, just as a point of interest, I was actually active as improving the personality disorder pathway before it was even thought of, before I ever met Lulu. I'd been working for nearly a decade on it, on my own type of thing. So that's why I was so delighted to have the marvellous assistance of Lulu 4.5 years ago and right through to today and in the future.
Yeah, no, yeah, thanks. Right, if no one else has got any questions, I'll just quickly get my two in. The first one, Lulu, is in the paper, I couldn't see any specific referral route. So I'm just wondering how 14-year-old Sasha and 11-year-old Carl would gain access to those services without that dedicated referral route. And the other thing is we're saying it's going to take 3 years to sort of get, I heard what you said about the timing, etc. But just 3 years seems like an excessive amount of time to me. You know, we could probably say today, let's try and get to Mars, and we could probably do it in like 2 years. So I just don't see how the 3 years is fitting up when we've got such a pent up demand of people needing these services. So you could just answer
the first question's easier, so I'll take that one first. There's not a separate referral pathway. This is part of secondary mental health bread and butter and engagement with primary mental health. So we're not going to have a separate pathway that people refer into for the reasons we talked about earlier about exclusion. If you have a separate pathway that's distinct or disparate, then you have to have referral criteria, then you have to have inclusion and crucially exclusion criteria, then you have to badge it along diagnosis, and all of those things get complicated, and there is disagreement, and then there is distress because people aren't meeting those criteria when their need could still be met by the treatment. So our needs typing screening is the way to identify if the need can be met through the treatments that will be offered and delivered. So it's the needs typing screening that will be, people will be trained up in primary care and secondary mental health care, and then offered the kind of personality disorder and complex need pathway interventions. So that's the first question. The second question, it won't take 3 years. It's not like we're going to wait 3 years and then start. We are starting now. We have already the training program that Carl and Sasha have created. We've already started delivering that to our staff. We're already working with the homeless forum in Suffolk. We've started delivering it to them. We've worked with A&E colleagues. We're starting to deliver it to them. So we are beginning elements of this pathway where we can. And a lot of the training is underway and the planning is underway. We've got recruitment kind of beginning, or that the kind of planning behind that beginning already to deliver the more specialist kind of intensive treatments. It's 3 years before, in all likelihood, you're seeing evidence of change in all of the mental health acute wards, in the CRH teams, in the emergency kind of response services, in the community mental health teams, and in primary care, because of the slightly clumsy analogy I made earlier, but the fact that people are already, their diaries are full, they are already working on additional things. So it's about trying to lace this into what they're already doing. It's that takes the time. Right. If we were going to Mars, we'd have a dedicated team and that's all we would be doing.
Yeah. Okay. Just going back to my first question, I think that opens up a bigger question, because I assume Sasha and Carl didn't know when they were 11 and 14 that they had a personality disorder. So it's, how does someone who needs help at that age get access to the system? I mean, that's going back sort of further down the line, but we need to pick that up probably in a separate conversation from this morning. But that leaves that question open, doesn't it? So
it does, and crucially, I mean, it links to the point that Ed was making about working into schools, working into colleges, kind of skilling people up, and crucially, personality disorder is not inevitable, right? When people are beginning to experience emotional difficulties, struggling with their self-concept, their self-identity, finding it hard to manage their emotional pain, if we skill them up then they never develop a personality disorder, right? So it's about skilling up staff across the system to spot those signs and have the techniques in their pocket, so much of the effect of what we're going to do will actually we won't be able to measure it, because we will be preventing future distress.
Yeah, okay, that makes sense. Okay, I'm going to close this down now and actually go to the recommendation. And Eugene is asking us basically just to support the business case as set out within the paper. Is everyone happy to do that? Yes. Okay, that's approved then. So I'd just like to thank everyone that's contributed today. I mean, they were very powerful stories. I don't want to keep repeating what other people have said, but I mean, they were genuinely powerful stories. And, I can say with some certainty that we will get this right within a space of time anyway, and it won't continue as it has in the past. So, okay, thanks very much. You're welcome to stay if you want to hear the rest. You can stay for the rest of the mental health papers if you like. So,
thank you very much.
Thank you very much.
Thanks, Graham.
Thank you. All the very best. Bye-bye. Eugene, can you take us through the other papers?
Of course I can. Thank you, Chair. So just to pick up the other items to cover off, we've got an eating disorders phase 1 eating business case, which Sarah Cross will be giving us the headlines on, and John Harris for some investment going into East of England ambulance service. Just before we do that, the first part of the paper was about our mental health investment plan. So there's just a few key messages to share. The CCG met its mental health investment plan standard requirement for 2021 as audited, and we've submitted plans to NHS England as part of our 21-22 requirements to meet that standard again in the coming financial year. The paper sets out also for table 3 within the paper are mental health investments for 21-22, and table 4 for information sets out the service development, which is transformation funding to pump prime a lot of these investments, and also system recovery funding, which has come down from NHS England to help us recover from COVID. I'll now move to the eating disorders phase 1, but just setting the scene in terms of we have a phase 1 and a phase 2 due to the urgency of national trends in the demands for our eating disorders service, which is why the decision was taken to fast track this paper and bring it through our governance for hopefully agreement today. I'll pass on to you, Sarah, if you could just give some high level statements in terms of where phase 1 is hoping to get us to and where the investment is going. Thank you.
Thanks very much. Good morning. We've seen a huge increase in the numbers of young people and adults presenting with eating disorders, and I'm sure anyone who's had half an eye on the media will be aware of that in both a regional and a national context. The impact of that locally has been that we've seen a huge increase in the numbers both of children and adults coming to us for both a specialist assessment and for specialist treatment. We have as a team struggled for some time to meet the KPI for children's early intervention for an eating disorder, and also from an adult point of view, as many people, certainly GPs in the room may be aware, we've had a relatively high threshold for the people that we've been able to see, which has been something that we've had an ambition to be able to change over some considerable time. As Eugene said, this paper has been brought forward at an earlier stage than we'd anticipated than a full business case, and we know that we've still got considerable work to do on what will look like a full integrated pathway across the system with partners. This paper significantly focuses on the specialist service that we provide within NSFT. We're seeking additional funding for both our children's and adults teams across Suffolk to be able to move forward with an immediate recovery plan, which will allow us to be able to meet the needs of children and adults locally. The paper, which I hope people have had a chance to look at, sets out trajectories of if no action is taken, where we'll be in 20 months' time with the numbers of people coming through, and also sets out options for new resourcing in the forms of both staffing and a VCSE offer that we hope that we'll be able to move forward with. We've been able to focus on the types of staff that we hope to be able to recruit, and also looked at a retention and training programme for new incomers. And we've tried to think about this in a fairly pragmatic, sensible way, in that we know we're unlikely to recruit fully fledged eating disorder specialists to our team locally, and that we're likely to have to grow our own as such. And we've had quite a lot of success with that in the past. We have built in some induction programmes into the work that we have going forward, and there's also a trajectory built in terms of the staffing and where we hope people will be within 6 months of their recruitment. This is also the beginning, obviously, of a longer term piece of work which will take us into line with national services for people with eating disorders, which will allow us to develop our severe and enduring pathways for adults. It will allow us to do a scoping exercise to look at meeting the needs of children and adults with presenting with ARFID, and also allow us to develop our local marzipan pathways, which currently we have 4 underway with our acute medical colleagues, 2 in Bury St Edmunds and 2 with the colleagues at Ipswich Hospital. We also intend over the course of the coming year to be able to implement our free treatment pathway, which is for 16 to 25-year-olds presenting with an early onset and first episode of an eating disorder, and to establish aligned county teams for children and adults, which from a historic point of view have developed into very separate silos, and we're now looking forward to being able to align those teams to better meet local needs. The funding that we're seeking will also allow us to develop our medical monitoring pathways for both children and adults with higher levels of risk and need, alongside our primary care colleagues, which we know is an area of significant risk. And the recent coroner's reports in Cambridgeshire, the learning from those is that their pathways alongside the marzipan medical acute admission pathways we need to be developing. The overall goal of this is to provide an early intervention for people with eating disorders, and also to prevent out of area admissions, of which we've seen an increase both locally and nationally over the course of certainly the last 18 months has been very significant. We've also seen a significant increase in the numbers of young people and adults admitted to acute medical beds as a result of the complexity and risk of their eating disorder. We've developed a month-by-month plan to look at our immediate recovery and anticipate with the proposals put forward in this paper that we'll have a recovery trajectory of approximately 6 months for children for us to be able to meet the key performance indicator of an assessment within 5 days for those presenting with a high level of risk, and within 28 days for those presenting with more of a routine low level of risk, and that we'll meet the trajectory in terms of adult assessments and introduction of treatment within 3.5 months, and we will then be able again to meet the standard expectations for treatment to commence. Sorry, I'm just screening. I'm just flicking through my screen just to make sure which X. I'm aware it's rather a dense paper. I'm really quite aware. We've developing particularly a couple of nursing specialist roles for the adult team to be able to support the medical monitoring and also to be able to support the medical inpatients locally. This is quite a new development for us locally, and also is part of a overall plan to improve upon our retention of our nursing workforce. We know that we've had an issue to previously, with people leaving and going to other areas where they've have a better opportunities in terms of nurse advancement. And we also anticipate the development of our assistant practitioner roles within the team to be able to support the medical monitoring pathways. We've also have a significant investment request in terms of a psychiatrist for the adult team, which at the present time is sorely lacking and clearly needs to be, this person needs to be in place again to support medical risk and the complexity of the needs of the people that we're working with. We have a training plan in place to ensure that we provide all Band 6 nurses with a nice concordant treatment modality, and have been realistic in our expectations of psychological staff within the team, as they remain quite a limited resource.
I think, Sarah, if we can just sort of wrap up, I think the board have hopefully got the key messages in terms of.
Thank you.
Thank you very much. The urgency of the investment that's been brought forward, the fact that effort has gone into the recovery trajectories, which are obviously very important, and this will be followed up by the broader full business case by the end of June. If we could pause there, Chair, please, just to see if there's any messages for Sarah, and also Sarah Gibbs, I know, has joined us from NSFT as well now.
Okay. Any questions or query on that paper, Ed? And then Lisa?
Yeah, I mean, I'm extremely supportive of the paper. I think it's excellent. Could you say a little bit about how you propose to work with BEAT and Wednesday's Child? It looks really exciting that they're kind of built it recurrently into the funding model, which is brilliant, but just grateful for a bit more detail about how they'll be kind of part of the team.
Thank you, Ed. So we've already started recently to work with BEAT with the regional offer that's been offered for both for parent support, and the goal is that with the proposal that's built particularly into this paper is that for the people that are currently on our waiting list, we'll be able to offer every parent a specific intervention, and also every young person. There's a variety of programs with BEAT, including some group interventions, group support models, and also some slightly longer term programs, including a program for slightly older young adults who are awaiting treatment called Motivate, which is a particularly useful resource because it's actually working at supporting those young people who have had the motivation, the point in their lives where they feel that they want to access treatment for their eating disorder, and frustratingly then have to wait. And it's looking at improving on working on their levels of motivation to really maintain that encouragement to continue waiting for treatment. I think the options with BEAT all look excellent. They've done a lot. There's been a lot of research done into the pathways that they offer, and the anticipation we certainly have locally is to think about how do we actually utilise these in the longer term for people that may be waiting, and the potential that for some people that intervention may be enough to get them to a place that, for example, from a parent support point of view, they're able to do the support that's needed for their young person just to get back on track at a very early stage. From the point of view of Wednesday's Child, that's a relatively new working relationship for us. Wednesday's Child, as many people in the room know, has developed an excellent resource locally. They've really developed that working with people locally as well, looking at levels of local need. They've got a significant array of resources available, including quite significant interventions with psychology and family therapy, but also looking at supported shopping and supported meal planning, which are things that for people with, particularly with a longer term eating disorder, are areas of life that just get swept to one side, which for many of us feel very, very normal. So I think we're certainly anticipating that there's a very significant array of support with the VCSE offer.
Okay, thank you, Lisa.
Thank you, Sarah. I'm so glad for you to see this coming to fruition, because I know you've been working on with the eating disorder team for a long time. I just wonder, so there's some similarities between this and the personality disorder work in that early intervention, proactive services early on when we get the first signs and symptoms that somebody is experiencing mental ill health seem, and I'm sure there's huge evidence base in eating disorders around, you know, that putting those services in early. But I was just wondering, particularly with eating disorders, whether there is a step even before that. So before a family thinks, oh my goodness, this is becoming a real problem now, and taking their child or going to see their GP themselves, which is probably their first point. Is there enough education in our school system? Are we working with our colleges, our youth clubs, you know, all those services that work with CYP to pick up those really, really early indicators that actually let's do something quickly?
Thanks, Lisa. I think that I'm sure other people in the room will share a frustration that with the paper we're presenting today is very limited in terms of it's very much focusing on that specialist pathway, and certainly the wider business case is looking at the much wider pathway in terms of that early intervention stages and thinking about where do you go at a much earlier stage, and you're thinking about a specialist treatment intervention. And the goal that we have is to be obviously is that this whole system is working in terms of the mental health in schools teams, the support available within primary care, and the whole of the education to all of those areas is really significant. And that's certainly a key part of the wider business case, which is looking at the whole pathway of support, interventions, education for both young people and adults with eating disorders. So I have a frustration that we're not able to present all of that today.
Oh, we'll wait. It's coming, as long as it's coming.
Yeah.
It's coming.
Thanks for that, Lisa. Sarah?
Yeah, morning everybody. I'm Sarah Gibbs. I'm the Service Director for Suffolk CFIP. I just wanted to add a couple of points linked to what Lisa was asking, and also Ed, just in terms of the whole system approach that we're really focus on working together, really think about how Thrive actually fits really well for eating disorders in terms of thinking about what's an advice guidance offer, what do the pastoral teams in schools do. And we had a really good useful meeting recently with Public Health and Health Watch, thinking about, you know, we talk about the Thrive model and thriving. In terms of our eating disorder service and eating issues, it's where's healthy eating within that. So really thinking about actually what's the whole system approach, and how the specialist services can actually support the third sector. So really thinking about our consultation role in terms of thinking about what would a good advice and guidance offer look like, and what does the help offer look like. So where we're working as a whole system, really thinking about how we really strengthen the third sector, education and primary care, really thinking about, you know, the new PCN workers that are coming on board in terms of thinking about if they're working in primary care, working with GPs, how can we think about their role in terms of thinking about an eating issue? And then when do you get the specialist involved in terms of an eating disorder? So just, and that's really going to be at the heart of the sort of full business case in terms of the whole system approach and what that looks like going forward.
Great, thanks. Paul?
Yeah, thanks, Graham. Firstly, I'm hugely supportive of the paper, thank you, and totally accept the need to step it stone in terms of first phase, second phase, given where we are. But reading the paper and understanding the fact that we're looking at a 6-month recovery phase is really predicated on our ability to recruit staff into the service. And I guess it's a twofold question for me. A bit like earlier on, our confidence to be able to recruit the relevant number of staff that we need to be able to do the recovery. But at the same time, thinking about how do we safeguard the children that are currently on the waiting list, that are dependent and waiting for treatment and reviews. And I'm sure you must have thought about some of those elements in terms of how you safeguard those patients on the list. And I wonder if you could comment on that.
Thanks, Paul. Yes, so the request that we have in the paper in respect of the VCSE packages is in part, the main part of that is to support the people that are waiting on both the adult but particularly the children's waiting list, which is, as you can see from the numbers in the paper, is growing. In terms of the, so as I said, that will provide both a parent and a child intervention, and also the packages with Wednesday's Child will provide some additional support for both people who are waiting for an adult service and also who will be stepping down from an adult service. In terms of keeping people safe on the waiting list, everybody that's coming into the service is currently triaged within 1 to 2 days of arriving. That will be a significant lengthy call with a parent and a young person looking at current risk, and we have to say we're also quite dependent on referral information to support that risk assessment. And then we're also looking at obviously trying to provide an assessment within a timely period, but we are aware that the waiting period is getting longer. So we are providing both physical health check clinics, and have done throughout COVID, for people who are on the waiting list who are at some risk of deteriorating possibly more rapidly. We're also providing check-in calls for people at regular intervals and looking at how those can also be a supportive intervention rather than just a type of tick box exercise, and ensuring that everybody on our caseload is aware of how they can access support from the team, both in hours and obviously outside of hours from the crisis service if required.
Thank you.
Sorry, and that's from an adult and a children's point of view, obviously, as well.
Okay, thank you. Sarah?
Yeah, I just wanted to add to what Sarah was saying. So just really thinking about what we do whilst we try and recruit. Obviously, Sarah's talked about some of the areas, but also thinking about our recruitment campaigns. So really thinking about how we're actively thinking together as a whole CFIP in terms of our recruitment. So really thinking about the bands and actually what we have to offer across the board in terms of bringing in new staff and you know what specialty they might want to work in. We've got a consultant psychiatrist for the under 18s that we've just advertised for recently in terms of a generic role, who's actually interested in working in eating disorders. We're also noting a start of a change in terms of, as we come out of lockdown, in terms of people starting to apply for posts. So that's really positive. So really thinking about our recruitment campaign and thinking about, you know, what Suffolk has to offer, and also thinking about the training packages that, you know, we want to put in place to really actively encourage people. So we don't underestimate the challenges of recruitment, but we're actively really thinking about what we can do to make the eating disorder team in Suffolk the place that people want to actually come and work in.
Great, thank you. Hannah?
Hi, morning. I'm Hannah, one of the mental health transformation leads. I've been working with two Sarahs and the rest of the team to help pull the business case together. I just wanted to really add to the VCSE point that we're also working with Suffolk Mind to develop a much more robust recovery offer. So they currently run, I think it's one recovery group fortnightly for a very small number of people. So they're another partner that are very much at the table. And we had a system-wide workshop a couple of weeks ago to bring everyone into the room to start identifying those common gaps and help co-produce what that future offer should look like. So that's going to be an ongoing open conversation.
Great, thanks, Hannah. Eugene, do you want to say anything just before we actually put the recommendation to the board?
I think it's just yes to seek agreement, and then we'll have the final item for mental health. Thank you, Chair.
Okay, Sarah, did you put your hand up again? Did you want to say something? Just
it was only very briefly. It was just if I could jump in at the very end. I'm also aware that the work that Lulu's presented, obviously from a co-production point of view, is something that we're aspiring to. We're hopefully very shortly having an expert by experience recruitment event, because I think one of the things we've learned over many years is that we've worked with a lot of people that are really, really keen to put back their experience into the eating disorder treatment pathway. So we're looking to have that event hopefully very shortly to encourage young people, adults, parents and carers to engage with us to move this pathway forward, to support ongoing training and also to support us with ongoing recruitment. Thank you.
Thank you very much. Okay, just going on to the recommendation then. Does everyone support the paper as written, as detailed? Yes?
Yes.
No, okay, yeah, go ahead, we'll approve that then. The only thing I was going to say, just following on from this, because both the personality disorder and the eating disorder paper, I was thinking, should we have like a follow-up in 6 months' time just to track progress? But then I think, following on from Paul's question and Dean's question, I just think that's probably our bread and butter in terms of working with the providers and actually holding them to account. So I'd assume that you'd do that in your normal sort of day-to-day work. And I mean, unless people do want to have a follow-up in 6 months on these two papers, I don't know, Ed, what's your feeling on that?
I think it's so important that a follow-up would be a good idea, Graham.
Do you think so? Okay, yeah. In 6 months' time, can we do that then? I think we'll still be a CCG, I think, in 6 months, won't we? Just about. So in five or 6 months anyway, somewhere along there, before we finish anyway. So, okay, two really great papers. So I thank everyone. Hannah, would you like?
I just wanted to add, I've also been working with Lulu and the team on the personality disorder pathway. We're planning a sort of formal launch event at some point later this year, so we can make sure that our update ties in with that as well.
Great, thank you very much. Okay, we'll move on from
Graham.
Oh, sorry, beg your pardon. Yeah, Dean.
Could I just quickly sort of come in?
Yes.
Because this has been both those papers were brilliant, but because there's been risk and unfortunately failure for so long, can we make the follow-up 3 months?
If people feel they'll be sufficiently progressed in 3 months, I mean, I'll be influenced by what, Paul?
Apologies. Yeah, so there'll be a natural follow-up based on phase 2 a business case, I guess. So if we could wrap up some progress report as part of phase 2 request, that would seem to be an appropriate way of doing it.
Okay, when do you think that will be available, Paul?
I'd have to defer to Eugene on that one.
But we're expecting the final business case by the end of June. So the subsequent governing body we can come through, Chair.
Okay, great. Thanks very much. Are you happy with that, Dean? Yeah?
Yes.
Okay, great. Thanks. So we just move on to the fourth and final paper, which is the E-East mental health team expansion paper.
So if I can just set the scene, please. There is a requirement within the mental health long-term plan for systems to support the ambulance service in terms of our response. John Harris, who will come in a minute, is our regional lead, our commissioning lead, working with the East of England Ambulance Service with all systems. John has a proposal from the East of England to effectively look at investment across Suffolk and North East Essex ICS footprint. This has failed in the past due to systems not being able to come to agreement across the East of England. We have funding set aside for this, and we've regionally had discussions to get broad agreement across all other ICSs, with the caveat that the East of England work with our local Suffolk and North East system to ensure that they work with our local landscape and our local providers. But if I could ask you to come in, John, please.
Thanks, Eugene. Good morning, everyone. This is a trial basically to see how we integrate Nines better with community mental health response at the point of crisis. So we're looking for a dedicated mental health professional to work with the Nines on scene, particularly to support those patients who have dialed the Nines and are in crisis, but also to support the crews who are often left with a very challenging patient, and often there are long delays on scene in terms of trying to resolve the outcomes for the patient. We know it's working across the country elsewhere, and we feel that this is the best way we can trial something to better integrate the Nine response with mental health. We do know that they will work very, very closely with our other services in the community, and with the existing Band 7s that we've got working from the control rooms, we know they're a bit too remote to really help. So whilst it's a bit light in terms of actually the investment at 75k across all of our ICS CCGs is very, very light, we are aware that we need to just almost light trial something to then better inform us how we might integrate the Nines with mental health crisis response. better going forward. So the key outcomes really for us is to try and reduce the pressure on EDs, but also to try and de-escalate where potentially the outcome has been a section 136 or 135 for those patients, and obviously to try and support crews and patients at a very, very difficult point in the patient's journey. So this has, as Eugene said, got full sponsorship from NHS England as well, and I am trawling all the other ICSs to try and get approval through by the end of May. So I'd be very, very grateful for your support on this.
Okay, great, thanks. Are there any questions from anybody on that? I think the paper was relatively straightforward. No? Okay, can we approve that as per the recommendation? Yes? Great. Thanks very much, John. Thanks.
Thank you, Graham.
No worries. Okay, I think that's it for the mental health section of the paper, isn't it? I think we've had some good discussions there, and it's, you know, a lot of good work that's really taken place there, isn't it? I mean, it's, you know, probably long overdue, but at least it's happening now, isn't it? It seems this sort of alliance system working seems to be pulling things together, doesn't it, and just moving it forward. So thanks everyone for their efforts. Okay, on to agenda item 8, which is nicely in view what I was just saying, Maddie, about the alliance working. So you can
yeah, thank you. Perfect cue. So I'm really pleased to present on behalf of the Alliance partners our second annual report, and to thank all of the contributors, and particularly to Rachel Bottomley, who's worked to bring this together. So as you're all aware, and is so beautifully articulated in the previous items, at the heart of an alliance is people working together, organisations working together with patients and the public, on the absolute premise that we can achieve a better process, and even more, a better outcome by working in this way. So the plan for 2021, I remember the day of the discussion and the final approval was the last time that I met with anybody in a meeting, and it was in a small and shrinking room as some were starting to dial in. And at that point, I think we genuinely didn't know exactly what lay ahead of us in terms of COVID. So our plan was approved in that context. And we spoke critically then about our mission, our vision, and the values. And those values, I think, have been so important in the course of this year, and I think have been well upheld. There's always times, but I think have been well upheld of collaboration, compassion, creativity, community focus, creating one team, and cost effectiveness. And as you'll know, we've stayed very consistently in having 3 programmes of work to deliver our objectives, our outcomes, and our mission. And they are the transformation programmes, of which mental health, which we just heard, is an absolute core plank, and others in terms of elective care and of integrated care, cancer, and others. The connecting actions, which really speaks about how we're going to work together, how we're going to deliver, and particularly important within that group of actions are our integrated neighbourhood teams and our work within our localities. And the third set are our enabling actions of our workforce, digital, communication, and premises. So these 3 sets have all been, if you like, scored progress within the report, and that's been done through a collective exercise and reviewed by the senior responsible officers as well. And you'll see through that there's some programmes of work that through this year have accelerated, needed to, and have been accelerated. And examples of that would be the Discharge to Assess programme, social prescribing, our work across the whole in terms of end of life, digital, which has seen a revolution, I would dare to say, and our integrated neighbourhood teams working as one teams within a community. And I think also our governance. We now have a really vibrant board, we have an executive delivery group, and we have well-functioning committees and work streams in support. So I think that's been a massive change over the course of the year. There's a way to go with all of these. So these are things that have really accelerated. this year has shone a light on some areas, as we know, where we may have made progress, but we realise there is so much more to do. And I think inequalities and our work to ensure equity of outcomes is one area where we've made progress, but we know, and the vaccination programme is an absolute example of this, we need to keep going and to do more with our communities and with all organisations working together. And then finally, the report describes a set of actions which have been delayed or have had to be done differently. An example of that would be the prevention programmes, where plans for people to meet, to exercise together, to work in schools, etc., have simply had to be paused. But we've had to find other ways as well to achieve that. And again, digital has been so powerful in that. But also we've had to focus on prevention in terms of COVID. So many of those actions were quite rightly included in the plan and will transfer into next year's plan. So the plan sets out, as I said, a RAG rating for each of those areas, and it describes some case studies, because fundamentally this is about the difference that working together makes for individuals. And then it also looks at outcomes, because it's also about individuals collectively and what difference we've made for our whole population. So that's the report, and I commend the report to you and thank everybody again for all of their contributions. The next stage is what are we going to do next? What's our delivery plan for 21-22? And that work is ongoing. Ideally, of course, normally we'd have had this ready for the 1st of April. We're not quite in that space, but it will be ready by the end of June, by the end of the first quarter. It's a very inclusive and engaging process. And we have talked this year about 6 priorities, and I just wanted to share those with you for now as an interim step. They have come from listening to the integrated neighbourhood teams through the One Team programme and our colleagues on the ground. They've come from listening to the feedback from work streams and with the input of the boards. So they are in no particular order. Does that sound a little bit like an event last Saturday that we don't speak of? Self-care and prevention. Community-based services to manage demand and to help people stay well in their communities, implementing the mental health community model, is the third, reducing inequalities, COVID recovery and management, and the alliance development, the development of One Team, the development of our governance in the context of the integrated care system and the journey that will go on. So they're the 6 provisional priorities that we have for now. So I'll leave it there. I'm happy to take any questions, but I'm also even happier to field any questions to others, because this is really everybody's report, of colleagues here and of the wider alliance. Thanks, Graham.
Okay, thanks, Maddie. Any questions or queries for Maddie? Lisa?
Maddie, can I just ask one question? It's really difficult when there's so much to do, isn't there? Getting the 6 priorities to kind of encompass everything that needs to be done. But I'm very mindful we've got the leader reports on the agenda, and there is a massive national transformation plan around learning disabilities. And I just wonder whether we can look at making sure that within those 6 priorities, so reducing inequalities and the prevention, all the way, we can make sure that we're really explicit about the interventions that will support people with learning disabilities to have better outcomes, and whether we can just make sure that all the national work is fed through that somehow. It's just sort of, yeah.
Absolutely, yes, and thank you for raising that. And I think maybe there's something else I should have said about the priorities. So all of the work that's planned in all of our areas, in the transformation actions, connecting and enabling actions, is continuing. The purpose of the priorities was to ensure that they were having particular attention from the board in terms of our progress. So all that we're doing will continue to be monitored and to be reported. But this was to say, if there are 6 things that we really must keep the closest eye on this year, what will they be? So that's the kind of genesis, if you like, of the priorities. But I do think thinking about particular patient groups is really, really important within that. So absolutely, we can ensure that does happen.
Yeah, good question, Lisa. No, I thought Ed was going to say something there. Okay.
I will do.
I thought I could see Ed, you were sort of 50-50.
You can see the cogs whirring, but there's no output. So it's just on cardiovascular disease, which has a page in there. That's been a bigger killer than COVID in the last year. And I wonder whether, because we've understandably focused a lot on the COVID response, but there are other big threats to health, aren't there? And I wonder whether we need to, with clinical support, just sort of revisit some of those disease challenges and see where we need to kind of raise our game in the coming year.
Yeah.
That's it, and I'm sure this must be the right moment to hand over to clinical colleagues. But I think that one of the things that we do plan to do is a very early step now is to have some really in-depth conversations with our public health colleagues and our communities, as well as with clinicians, about the whole prevention agenda and the early management agendas for cardiovascular and for other diseases, and to see what I think, we referred to the plans that we had. I suspect some of the plans that we had not only now need to be followed through, but need to be broadened, deepened and accelerated. And I think that's going to be one of the questions that we need to answer. Do they? And if they do, how do we do that? And how do we do that together? But Aisha's got a hand up, so she may.
Yeah, I see that. Yeah, Aisha.
Thank you, Maggie. I think you answered it better than I would. I would just say that we will bring population health management, and this will be covered through that, the work we're going to do across the PCNs. Because definitely in my PCN, when we did the population health management data collection, cardiovascular risk was one of the high ones we picked across the board, especially in our patients with SMI illnesses. So Ed, I think we would be picking up that piece through population health as well.
Lorna and then Paul.
I'm just saying I agree about the cardiovascular disease, but also I think we need to step one step earlier than that. We've been talking a lot about mental health and about intervening early, and we should be intervening earlier with the general population. One of the reasons our COVID death rate has been so high is because we have an unhealthy population, and we've got to face up to that, and we need more preventative programs for obesity and more of a drive to encourage people to keep fitter, which will in the long term make healthcare a lot cheaper in the country and lower the risk of cardiovascular disease and diabetes and everything. So we've really not grasped this enough, I don't think, as a CCG over the last decade. I mean, I really believe that, and I think that has to be as a thread right through if we can. And obviously our public health partners are absolutely key in all this as well.
Yeah.
Thank you.
Thank you. Paul?
Thanks, Graham. I was just going to make a natural link to some of the other pieces of work we're currently doing. So if you look at our recovery piece on elective and high volume, low acuity patients, one of the priorities are reviewing cardiology pathways. So again, there is an absolute link between reviewing pathways, including primary care colleagues and co in terms of reviewing those pathways and making an impact on planned care and prevention of patients. So absolutely, I think we need to create those links.
Yeah. Yeah, I was just going to say, Maddie, you have made progress over the last year, but I mean, you've done it under very difficult circumstances, haven't you? And I think you're only just now really starting to gain traction in terms of looking at, particular work streams. And you can see by the comments that people are feeding in now that they're saying, we now need to get targeted on various sort of pathways and work streams and really make it, bring it home and deliver it. So I think you'll really now start to really take off. And I mean, the Alliance is sort of like the beating heart of the local delivery, isn't it? Where the ICS is more of a system. So I think you've done really well, given difficult circumstances. Imran?
Yeah, question for Ed really. With the white paper and public health, where is that going to sit? Because ideally, we'd want it a lot closer so we can have that more nuanced local public health approach. Because I think it's probably been fair to say the last few years it's been quite tricky with public health. There's been so much top down coming to them that it's been very difficult for us to, get them back in and embed them in the local system so they can help to drive that. Is that coming back to the ICS space, or are we going to have that more local feel, Ed?
That would be the ambition, but it'll be sitting within the local authorities, but it needs to be much more integrated and a kind of community alliance space. And I think that would be the intent in Suffolk, and that's some of the journey we've been on, but we need to go a lot further. So it's an absolutely good challenge, Imran, and we'll keep hold of that.
Okay, if there's no more questions, Maddie's just asking us to note that paper, and is everyone happy? Yes. Okay, thanks very much, Maddie, for all the work that you do. I think everyone appreciates it, so thanks very much. Okay, so moving on, Paul, to the procurement update.
Yeah, thank you, Chair. So it's essentially a paper to note, and I will take it as read. But if I may just pull out a couple of things out of the paper, which I think are in line with probably some of our conversation we've had today. So I think the first thing I'd like to say is around the neural development of children's services, which in my mind is really quite exciting. Essentially, it builds on as you know, builds on the Thrive model that we've talked about extensively, so particularly around prevention, intervention, and ongoing support. So some real synergy with the PD conversation we've just had. So, but in terms of procurement, it's just because we are in moderation as we speak, literally as we speak. So we should be ready to make a recommendation sort of in early June. Essentially, that will mean that we probably may have to set up a Part 2 governing body to agree and sign off. But hugely exciting, a tremendous amount of work that's gone on and really reaching a conclusion. So again, really good progress on that. The second bit I'd like to pull out really is the pathology. We've been talking about pathology for quite some time, and we've still sort of been hampered by COVID essentially, but it's just to say that service specifications are being completed and stripped back and reviewed. They're going to be moving forward into clinical scrutiny committees. That going well, we will then be quickly writing a paper in terms of the process around procurement, because it is quite extensive procurement. So again, some good progress on that given previous discussions. And finally, I'd like to pull out the mental health element of the procurement paper. We've heard a lot about mental health today, which is absolutely the right focus. Again, service specification due to be completed in early June. That will allow us to move very quickly to an assurance piece in terms of partners within the system, but more importantly, allow us to identify the gaps we may have in the services where we may need to go out to procurement. And again, a real opportunity then to engage much more widely in terms of service provision around mental health. So for me, those are probably the key three things in terms of ongoing procurements at the moment. And finally, just a note, which I know is a single paragraph in the paper, but we are still awaiting sort of legislation changes around procurement and competition law and all of those things. And clearly we'll be keeping a watchful eye on that, and we are actively engaged in some of the conversation. And as soon as we're here, we'll be able to provide some feedback on that. And I'll stop there. Happy to answer any questions.
Fanwell?
Thank you, Chair, and thank you, Paul. So my question is more general than some of the specifics you touched on. Now, sort of reflecting on the period that we've just gone through, the things that particularly from a community engagement, the things that have been talked about and the focus that we've taken is around inequalities, and some of the commitments that we've made. I mean, looking at the evolving procurement, sort of work program, can we say that we are sort of taking that kind of sort of differential investment approach that has been asked for by our communities, and that the work is actually reflecting that we are working towards closing that inequalities gap?
Okay, so I think the short answer to that is from a pure procurement point of view, we are duty bound to include health inequalities as part of our assessment of procurement. What I would say, though, is probably we need to go further and work much more closely with some of our local authority colleagues, for example. And I've been to recent meetings where we've had that discussion in terms of what else do we need to do? How do we need to work in partnerships? And our procurement specialists, if you want to call that across the system, are currently having discussions how we might enhance that approach as we move forward. But from a purely sort of a legalistic point of view and statutory point of view, we are asking the right question in terms of social contribution, if you want, to procurement. But I think we need to go much wider, and that work is ongoing at the moment.
Thank you, Bon.
Any more questions with that? I think it was relatively straightforward, the paper, wasn't it? Yeah, I always think, Paul, your portfolio is so big, isn't it? I mean, and yet when you just talk about the procurement, you think, well,
it's a minefield.
Yeah, and you just look at that and you think, well, you must be, doing more than that. But I know it's just because we're looking at one little specific. But yeah, okay. All right, I think we're just being asked to note that. So is everyone happy to note it? Yeah, okay. Thanks very much. And then Lisa on the learning disabilities paper.
Thank you, Graham. I'm going to hand over, if that's okay, to Wendy Scott, who's going to present, who is our head of LD transformation.
Thank you, Lisa. So I hope you've all seen a copy of the report, but I'll just talk through the highlights because it is, I think it's 27 pages long. We continue to do quite well in terms of meeting our trajectories in Suffolk and have achieved 100% reviews within the 6 months time frame. We continue to have the same governance we had previously, which is that we have a leader steering group which takes forward our action into learning from our reviews, and that is then fed through to the Transforming Care Board. Just a point of note, the Transforming Care Board will be renamed eventually the Learning Disability and Autism Health Improvement Board, so it fits in with the long-term plan commitments for people with a learning disability and autism. And our governance also continues with our regional NHS colleagues in terms of we're an active member on the Regional Learning Disability and Autism Board, where this is fed through to, and also the Regional Learning Disability and Autism Health Equalities Board. So we continue to do quite well with meeting our trajectories. And since the programme began, we have now received 100 notifications, 66 for East, 44 for the West. And within this last year, given the pandemic, we've received 42 notifications, 24 for East and 18 for the West. When we break down the analysis of the notifications that we've received, we can see we've had more referrals for males than we had females. Less than 3% have been from our ethnic minority background for people with a learning disability. And the median for age is 58 for males and 63.5 for females. So we're still below the national average of death rates for people in general for our population. There's been a decrease in the number of individuals passing away in hospital to 62%. But we continue to have some common themes. So 36% of individuals were due to respiratory conditions, pneumonia and aspirational pneumonia. And the second cause of death was sepsis. 57% of reviews completed assessed quality of care as being satisfactory or above. And I'm just going to put this in here just because I like to keep going on about annual health checks. 51% of the individuals reviewed were offered an annual health check and 48.5% had an annual health check. Now, we'll never know whether there's a correlation, but we need to do better at that. I'm just saying that now. Now, given the pandemic, we don't know what the national picture is in terms of it hasn't been published, but rumour has it we've done reasonably well. We're not an outlier for a huge amount of concern for people with learning disability and autism. So during COVID, we had 7 related deaths, 5 for East and 2 for West, which I think is actually quite remarkable, given that most of these individuals live in residential or supported living schemes and don't necessarily understand the rules around hand space, etc. On page 16 of the report, you will see that there's a chart with the thematic learning Now, most of this is not mutually exclusive for people with a learning disability and autism. And I think that's something which we need to take into consideration. So we know that when we have a look at our dementia population, there's going to be some common themes around mental capacity assessments, around bowel care, around having those physical health checks completed regularly and then being of quality. We know that postural care for individuals is a common theme across all of our age groups, and health facilitation. Now, we've done a huge plethora of work already. So we continue to have a named responsible officer, which is Lisa Noakes, and that really holds the system to account and is integral to implementing the long-term plan for individuals. We continue to have a quality focus. So we're very good in Suffolk at meeting trajectories, 100%, you know, we're quite good, but we need to start thinking about actually data is really important to hold us to account in terms of the number of people we see and the timeline we're given, but how do we know that's of any quality? So we're continuing to do that piece of work, and we're beginning to look at health action planning and annual health checks in particular to make sure that they're meaningful activities when they take place and that actually there's a journey for individuals. We have just begun to start on developing a physical health register, so a physical health dynamic support register, and this will be aimed at individuals who either have a range of highly complex, high-risk physical health needs or who have not had an annual health check. Now, there'll be a plethora of reasons why someone might not have had an annual health check, but we need to understand why that is and support those individuals. Time and time again, it comes up about health facilitation and desensitisation as reasons why people don't have their health needs met. So that's a significant area of work. We've worked really hard with our voluntary sector, and for us in the LD work, that's ACE Angular, and they continue to produce a range of easy resources and anything we ever ask them to deliver, including COVID and how to do hands, face, space. They've recently been producing work around screening and how to go and have your screening test for cancer or breast screening or well-manned clinics. So they're really quite integral to supporting our cohort to make sure they continue to have their health needs met and understand what will happen when you go to have those health needs met. Our GP registers are currently up to date and have been reviewed annually, and that will continue to be done. We know there's a piece of work we need to do for the 14 years plus, but that's in progress at the moment so that we can make sure that they are up to date and we're actually ensuring that the right people are having their health needs addressed at an early opportunity. And there's been some triangulating of information to make sure that we've got digital flagging for individuals that need reasonable adjustments, but also digital flagging that if you need an annual health check, you're going to need a flu jab. So they're beginning to triangulate the information to make sure it's all in one place for these individuals. Now, our key areas of focus moving forward will obviously be the action into learning, but specifically we've been looking at a transformation programme for health services for people, and that's called Priority 4. Now, it's not, this is a bad thing, but at the moment our learning disability specialist health service sits within Norfolk Suffolk Foundation Trust, and that's absolutely fine, but we mustn't get confused with it being a mental health model. And I keep saying that everywhere I go. They're very highly skilled in meeting people's needs for learners with autism within that framework, but it's not just about mental health. So a significant investment over the next 3 years is actually looking at health facilitation. Now, at the moment, that role is called GP liaison nurses, but we're trying to change the focus away from it being for a GP and for being for actually the individual and what they might need to support them on their journey. Because actually, when we have a look and start unpicking and start talking to people, how many have had an eyesight check? How many people have been for dentists? It's not just about accessing our primary or secondary health services. It's actually accessing all of those things we all take for granted. How do we teach someone to wear their glasses if they need them? The primary, those nurses, the health liaison nurses, will be meeting the needs of individuals from 14 plus. And that's because the annual health check should be offered to individuals from 14 plus. And we know that there's a bit of a cliff edge for individuals who are open to paediatricians and when they start that transition. So hopefully, if we start early and start doing those pieces of work from 14, we'll have continuity of care through those really vulnerable times in individuals' life, and transition is one of those, from leaving school to moving into adult services. Reasonable adjustments, I always say with a smile, because it is an absolutely huge piece of work that we need to ensure that our whole system is signed up for and completely understands what that means. Interesting question. So when we talk about reasonable adjustments and we talk about why individuals might not go and have their annual health needs met, you know, for me as an LD nurse, you know, if you go to visit your GP and they're wearing scrubs, that in itself can be quite frightening, quite intimidating. So there's a whole piece of work that we need to do, and we're very lucky that ACE will be helping us deliver that within our community. And our starting point would be actually walking through some of these areas with people with a learning disability and understanding what they need and providing that education and training from them around reasonable adjustments. Mental capacity awareness, I mean, it's not mutually exclusive to this pathway, but is a huge improvement programme across all of health services. Whether you've got a mental health problem, whether you've got a social care need, it is absolutely massive, but it has been really highlighted as within our LEADR reviews that have taken place. And we know we've got still need to do better work around individuals who are end of life for this cohort. You know, they have the same rights to receive the same service as anybody else. They still should be accessing, you know, hospices, etc. So we need to make sure that's in place. The other area is that we know that when individuals are palliative care is around them having end of life planning in place and it not being ignored just because they've got a learning disability and have various care plans. And that's part of what our transformation will be looking at as well, is coordinating that. Now, the other area, just to bring to your attention, is that moving forward, the LEADR programme is changing. And there's been a new policy, which has came out March 21, so just came out really. And it will no longer be about just learning from death. It will also be about learning from life and death of people with a learning disability. And there's a big change coming, and that's really helpful. So there's workforce implications from how we actually deliver that programme of LEADR reviews at the moment. But there's also the shift, which wouldn't be unexpected, to move from it being just about a CCG to being an integrated care system response. Now, I have said previously, and I still stand by that some of that is a name change for us. I'm really proud of the fact that actually we already work with these key partners around our table. So if we look at who sits within our current LEADR steering group, they are our key players. You know, we have everybody invited to take part, because it's not just us that need to hold that ring of responsibility and then affect change. So the transition period, moving to the new policy, will be over a 3-year period, but we're supposed to start it from April 22 next year. A significant difference will be, will also include individuals with autism. So that's not individuals who, you know, are written in their notes they might have. It's actually those with a concrete diagnosis, and it's on their medical notes. Now, there's a lot of anxiety about that, but I heard from Region recently that actually, at the moment, last year, there was about 300 deaths nationally for people with autism. We know that's not going to be accurate, because we also know that every area of the country is suffering at the moment with having a backlog of individuals not having their ASD diagnosis done in a timely fashion. So we do expect that to increase. But I think it's really valuable that we acknowledge that now, that that's a piece of work that we're going to have to do in the future to make sure that very vulnerable people's needs are met. And I think that sort of is a whistle-stop tour of the LEADR policy.
Okay, thank you very much, Lisa.
Thank you, Graham. Thank you, Wendy. That is, as always, incredibly helpful insight. And obviously, we are required to now publish that paper on our website. That's part of the national ask. I just want to highlight actually the massive amount of work that that Wendy is leading on RLD transformation and quality improvement work. When you look at the priorities that Wendy's listed. It's huge, but I do think we need to challenge ourselves as a CCG to also think about, so there are the separate pieces of work that Wendy's leading on for people with learning disabilities, but I think we've got a little way to go before we are really thinking about all the work we do. How are we making sure that people with learning disabilities have equitable access? So through our accelerator program that we've talked about, through all the work that we talk about, I think we need to constantly challenge ourselves to make sure that we are always ourselves thinking about how we're making reasonable adjustments for people with learning disabilities to be able to access the services we commission. And that's our ambition this year, is to really bring not just the very specific pieces of work that Wendy's leading on, but actually how do we make sure that all our MDTs that we have functioning within the CCG are thinking about people with learning disabilities. How are we making sure that all our primary care services are always, through our screening and everything, are always thinking about equitable access for people with learning disabilities? And that's really exciting, because that will take us to a great position. But we are on a real journey, and we have a really strong ambition for learning disabilities in Suffolk. Thank you.
Thank you, Lisa. Maddie?
Thank you, Wendy. So I think I'd really welcome the opportunity to talk some more with you personally about the health checks. You make obviously some really important points there, and I know that there's colleagues, GP colleagues, that you're working with. And obviously, there's been, in the course of the last year, perhaps some particular challenges in seeing how to ensure that the health checks are delivered. But I think there was a lot of progress in the last half of the year in ensuring health checks were undertaken. I also think there was a lot of learning through COVID and through the vaccination programme about how to support, engage and provide a really personal and responsive service. So I think maybe there's some learning through that period that could help us as we go forward. And I'm certainly very aware of the work that is happening in localities to bind together the health check with support in accessing screening through particularly one of the units that I sponsor, where it's an absolute commitment and priority to try and increase those levels. So I think, thank you for flagging, and I think just to ask for some more personal involvement, I'd welcome that chance, and to see how then I can help further.
Thank you, Wendy.
Yeah, good point. Paul?
Thank you, Wendy. Thank you for the excellent presentation. Something you've just said has caused me to reflect slightly, and it's sort of linked to the conversation we had earlier on around PD and the need for prevention, and the autism bit in particular, where it seems to be dependent on diagnosis. When we know that autism as a service is one of those services been under pressure because of COVID in terms of throughput and activity. So there is something in there about how we provide the support to folks who may still be waiting for diagnosis in terms of health checks and other things, and how we move toward the prevention and the right time, right intervention, which may not be dependent on diagnosis at a point in time. And I guess something for us to reflect on in terms of that conversation, not for an answer today, but something I will take away and have some thoughts about.
I could just update you really quickly, because it is really quickly. So there is some funding coming down from NHS England, specifically to try and reduce the backlog of individuals waiting lists for ASD, because it's a national picture, right, particularly for children, because children's ASD diagnosis takes a significant long period of time. It's done in various settings, adults less so. So that the children's transformation team are currently just putting a business case together to actually get some of that funding, and looking at the voluntary sector with how they support, and our adult pathway are looking to see what they could do using the voluntary sector as well. So I haven't got a concrete what it will look like, but those conversations and that piece of work is taking place, Paul.
No, that's fantastic. Thank you.
Okay.
Yeah. Wendy, I've just got two really quick questions, because we're running out of time. Actually, we're getting not just on your paper, but the whole meeting. One thing is with the new policy, I was in a meeting and I think Sally presented that. And we sort of now got this new super slick review system involving all our partners, the county council, etc. But the actual recording of deaths is not mandated. It's just that there's a strong expectation that they will be reported. So I just thought that was a bit of a weakness within. I know you're saying the new policy is about the living side of people with LD plus learning from the death. So I appreciate that. But I just thought that was such a big gap in the new policy. And just very quickly, on the health checks, the 75%, it just came to me as if we keep checking the same 75%, say every year we get to 75.1 and we think great. If the same 75% come back next year, that means that potentially 25% of people never get seen because they might be more reluctant to come forward. So how do we deal with that as well?
Okay,
Sorry for the detail.
No, it's fine. There's two things really. One is, that the ambition is 75%, but actually I think the East got 81% this year and the West 64%. So that's really quite good given the pandemic. Yeah. But for me, it's two things really, Graham. One is, well done for making a trajectory, but how do we know that was any quality at all with regards to the annual health check? So that's a piece of work we're currently looking at with our co-production partners in terms of what is a good annual health check? What does that look like? And what are the outcomes and experience of the people? And then the other bit is that physical health, I'm poking now at the screen, the physical health dynamic support register will look at those individuals with the most highly complex, high risk physical health needs who have had an annual health check, but they will also, so that workforce I was talking about as part of that priority transformation, the health facilitation, health liaison team, will focus specifically on that 25% or however many it is that haven't been and had an annual health check. Right. And that's why it's really important that when NHS England give trajectories, they ask us to do it in quarters. So rather than all leaving it to the last minute, because if we leave it all to the last minute, that the team are not going to be able to support the individuals that are most at risk, that really need the help. And there might be a plethora of reasons why they haven't, Graham. But we need to understand that and make sure that we're doing all we can to try and support.
Okay. No, thanks very much, Wendy. That's another good piece of work, isn't it? I mean, there's more in all the been top quality. It just reflects the amount of work and dedication that people put in, isn't it? So, and hopefully it will result for better outcomes for patients. So are we happy to approve the paper or just note it really, isn't it, Wendy? Are we happy to note that and the ongoing work there? Yes.
Happy for it to be published and also in an easy read.
Okay. Thank you very much. Thanks, Wendy. And
Thank you.
Lisa. Okay, let me find my papers. Right, I've written on my note. Do we need a break at this point? It's 12:15, so we've been going. I think there's one person raised that shook their head yes, so that's that. We're having a break. How long do we need? Is it 5 or 10 minutes? 10 minutes, okay, right?
I think can I just let everyone know that the recording will continue during that time, so make sure you're on
swearing. Yeah. Okay. So 25 past. All right. Thanks very much.
Just you and me, Graham.
When I was here on my own, Steve, I was thinking, hang on, have I lost the meeting? I just had a quick look at the ongoing agenda. I think we'll do all right. I was a bit flappy there, thinking, my God, we're like an hour behind, but I think we're okay with the second half of the agenda. Is everyone here? I can't tell if everyone's here or not. How do you tell? Joe, can you help us? How many people are still missing?
I'm here.
Oh, well done. Should we make a slow start then? Yes. Okay, can I hand over to you then, Jane?
Yes, thanks, Graham. So the next paper is a summary paper that brings together a lot of the work that we've been doing across the CCG and across the ICS on the plans for the year that started on the 1st of April. I'll assume the paper is read, but basically what we are presenting today is the kind of work in progress, very close to final position on the various different plans. So you'll see that on the 4th of May, we submitted a range of plans, and we're in the process of discussing those with Region and pulling together final iterations for the end of this week into early June. The plan, I think there are 7 elements of it. There's a narrative plan, which the pack gives you a description of that.
Sorry.
That section is being completed by Richard, and he indicates in there that the final version will come back to the governing body in due course. It's a template that's been sent to all organisations to complete in a standard format, and we've received some feedback on that from Region, very positive feedback overall, but a few bits still to update and complete. As I say, that will come back to the governing body. Included in the pack are details of the activity and performance plan in Appendix A, which if people have got questions, Paul will come in with any commentary on that. The workforce plan, Appendix B, which Amanda's team has been working on, and the resilience plan, which again Paul's team has been working on. It's a standard format, but it's been completed with the details for our ICS and CCG in particular. We've got the financial plan and budget in there, which if we've got time, Graham, I'd just like to run people through quickly, along with an update on what's going on with the cancer plan and the mental health investment plan, which we've already been through in detail in the investment plan paper. So I'm not suggesting we go into a lot of detail on that. So if I just hand over, Graham, to my colleagues to see if there's anything on activity plan or workforce plan, resilience plan they want to pull out. Otherwise, I'll just give you a quick update on the budget, if that's okay.
No. Ooh, Paul?
Yeah, I'm happy, Graham, to pick up some of the recovery elective planning side of things, if you want, very, very briefly. If you remember a while ago when we were discussing phase 3 recovery, we were given quite prescriptive targets to meet in terms of elective recovery. We have a very similar approach in terms of this planning with a slight difference. It's so much that we are being set aspirations. So you'll notice within the planning, we are supposed to be achieving, starting at 70% in April, rising to about 85%, 5% a month in terms of valued activity. That's the financial value, not the activity. Okay, that's an important differentiation. And essentially, this is then also supported by a couple of other things. Firstly, ERF, which is elective recovery funding, so aimed at not disadvantaging sort of system that want to go further and faster in terms of recovery of their elective activities. So there is no financial disincentive to doing some of that work. And the other element is predicated on meeting a number of gateways, which importantly picks up the conversation on health inequalities, picks up the conversation around looking after our workforce, and some of the things the system would be expected to have in place in terms of good housekeeping, elective process, etc. So I think that's quite evident within the planning guidance. I won't necessarily pick up on it now, but that's in some respect has been superseded by the accelerator program, which asks us to go further and faster, i.e. 100% by July, which clearly will need to make some adjustment to that submission as we move forward. But I think that's quite an important distinction from the previous recovery element that we had before.
Yeah, no, good points. Amanda?
Thank you very much, Chair. So I just wanted to underscore a couple of points reflecting the workforce plan. And whilst it's within the narrative, I just wanted to bring out that our approach to workforce is as a system, and we as a CCG are a key provider or a partner within that. And the system workforce plan is being driven by our SNE People Board, which is reflective of our wider system. And some of the key areas of focus going forward is the piece around our retention and obviously working with our Integrated Care Academy as a key partner as well. We also are focusing on the growing of our workforce, and again through the ICA route, but also in doing so recognising the importance of being an anchor organisation, which we think is very important to our workforce agenda. So they were the key points I wanted to bring out, Chair, but very happy to take any questions.
Right, thanks. Lisa, did you want to add anything to that? Not putting you on the spot, but no?
No, I don't think I've got anything further to add. Thank you.
Okay. Jane, then carry on the finance, please. I think this year is really important, isn't it? Because we're really close to, not falling in deficit, but it's very tight, isn't it?
It is, yes. So thank you, Chair. And obviously, as a governing body, we need to sign off the budget. We would like to have been doing this earlier, and we would like to have been doing it for the full year. But as people will have read in the paper, we've been issued as a CCG with an allocation for the first half of the year. So we're bringing a plan for that period. And obviously, we'll be working in due course on the second half of the year. So there's a lot of background in the paper, which I'm not going to take you through, about the way that finances are working in the NHS, and that the emphasis is on the system. So we've been working across Suffolk and North East Essex with our partner provider organisations, as well as the 3 CCGs. And you'll see in there's lots of discussion about the fact that we're continuing with the hybrid model that we had last year, where the CCG receives an allocation, but the vast majority of that funding is dictated both in terms of the way that we pass that on to our key providers, but also in the value that we pass on. So we have very little discretion in terms of the majority of our budgets, which comes into the CCGs and goes straight out to our main providers in line with the block contracts calculated centrally. So what that means is that overall the discretionary elements for the CCG are quite small. They're restricted down to effectively the running costs, the prescribing, and the continuing healthcare budgets, and you'll see in the slides that the uplifts for those have also been prescribed. Well, sorry, the funding provided to give uplifts for those has been prescribed, and it's quite low. So, for example, for CHC, the overall uplift is 0.2%, with a small amount for expected increases in demand, but that leaves us with very little additional funding and room for manoeuvre. So lots of things in the slides about the fact that there has been continuation of the national funding for COVID, again, which mainly comes into the CCGs and goes out to our provider organisations, and also continuation of the system growth funding, which helped us to continue a number of services we put in during the early days of COVID, such as the end of life services, working with our local hospices. And what we've done in the first half of this year is really to roll forward the arrangements on those. We've had to use some of that growth funding to fill gaps where there have not been sufficient funding within the resources available, but you'll see that there's a table within the pack on that. So moving on, if I may, to the CCG plan and budgets, just taking you through the slides on those. We have submitted a balance plan for that first half of the financial year that contains the first 6 months of that full year mental health plan. It continues those funding commitments from the second half of last year, particularly within the growth funding area, and there's a slide in the pack on that. Overall, because the funding settlement is constrained, and we do have some cost pressures within the CCG, to create that break-even position, we've had to utilise a small element of the COVID funding, and we haven't been able to re-establish a contingency reserve. Now, that's not really that surprising, because we were given effectively the same amount of funding as the end end of last year when we weren't funded for a contingency reserve. But it does mean that the financial position is probably more risky than we would like. And the slides go on to talk about the risks that are inherent in the plan and the efficiency savings that we are looking to start to bring back into play as we go through this first half of the year and ramp up into the second half of the year. The plan does exclude any additional agenda for change costs, with the exception of mental health. We're expecting that these will be determined and funded centrally, and the consequences of that will be passed on to the CCGs to go on to our providers. So I'm not going to go through all the slides, Graham. As you know, we went through this in detail with the Financial Performance Committee last week, and there were a lot of detailed questions about that. But the slides do go through, and they show the changes that have been made in terms of items that have become part of our baseline. So we used to receive separate funding, and they've been effectively rolled into our ongoing funding requirements. It shows our overall risks and mitigations, which are around efficiency, our ability to achieve efficiencies, some worries we have about non-NHS provider sustainability in the new landscape, and additional costs of independent sector. We put in a range of financial mitigations to cover those. There's a slide on how this CCG's element of the system growth funding has been applied, you can see, and final slide sets out, when we've done all of that work and we've added it all up, how that plays through into individual budgets for split down by directorates and by main programme areas for the CCG. So I'm sorry that's a bit of a whistle-stop tour, but effectively, as I say, the governing body does need to sign off the budgets. So they're here today for governing body approval.
Yeah, thanks. Yeah, as you say, Jane, we did go in real detail on that paper at the FPC, but I think one of the key things that came out for me there is that the amount of quip that we were trying to deliver as 3 CCGs and all the providers was so low compared to previous years. And I think you were saying because the PMO department has been repurposed, if you like, into areas of COVID work, that we're sort of really starting from afresh again with our quip plan. So it's like we're going to have a real slow, chunky start to get the quip back up. And that's, I mean, if it's needed anywhere, it's needed this year where we've got such a tight budget. So, I mean, could you just say a bit about what your work and plans is, how we're going to get the quip going again? And
yeah, so thanks, Graham. So we're aware that so effectively during last financial year, because the emphasis was on COVID, there was no overall requirement or specific national requirement for efficiency savings or quip, or whatever we want to call those, required of the NHS. What we're seeing is a sort of slow start on that for this financial year. So there is a national requirement for a level of efficiency, and you'll see that within our plan we've had to overall as a system put in a slightly higher level of efficiency than that, which reflects partly the fact that the funding that's come down is lower than the uplifts are quite low. So but what we know is in the second half of the year that discussions are still going on around the level of funding for the NHS, and given all the expenditure that has been experienced across the country, we do expect budgets to be tighter in the second half of the year, and part of the way that that will come through is through an increased national efficiency requirement. So what we are doing, exactly as you said, Graham, during last year, a lot of people were redeployed within the CCGs, quite rightly, to work on the overall COVID programme. But what we have to do is now start to push back into business as usual, particularly on efficiency programmes. So we've effectively got 6 months to get things going. We've got some requirements that we need to deliver in this part of the year, but we need to be really ready and have plans in place for that second half of the year.
Yeah. Okay, thanks very much. Any other questions or queries for basically the executive directors? I suppose it's a plan that covers all their work. No? Okay. Jane, can you just take... Oh, Imran.
Hi, sorry. I was just reflecting from FPC when we looked at the quip and the fact that it was very skewed towards ESNEFT. And I know we've discussed it. It might be worth just sharing with the rest of the board about the plans around making sure that we get a more equitable quip across the provider sector.
So yes, thanks, Imran. So I think there's a table in there somewhere that shows the breakdown of the efficiency savings, but effectively across the CCGs we've got a pretty even expectation around quip, but within that we pick up as a system, the 3 providers that fall into our control total. So that's ESNEFT, West Suffolk Hospitals and the Ambulance Trust. What we were discussing at the Finance Committee was that percentage of QIP included within plans was higher within ESNEFT than it was at the other 2 trusts, though they're obviously smaller because they're smaller providers. But there was further work to be done with them around understanding what was actually deliverable and how they were going to start to do exactly what we talked about to ramp up QIP and SIP, or whatever you want to call it, efficiency savings for the second half of the year. Further discussions are going on, particularly with the Ambulance Trust, around efficiencies that's required and their overall sort of balance between service delivery and financial delivery, which is probably going to mean that their assumptions are changing. For West Suffolk Foundation Trust, the main reason given for not being able to achieve a lot higher requirements is around the structural changes that they're dealing with around the hospital in the first part of the year. But I think we've got to, as a system, keep working with them around once those are done, how we will actually see significant productivity changes.
Okay, you happy, Imran, with that? Yeah, okay, thanks. Yeah, I'm just trying to think if you could take us through the recommendation quicker, or shall I just quickly try and belt through it? It's in paragraph 10. So what Jane's asking us is to note the plan, the narrative and the cancer plan. She's asking us to approve the draft plans for the activity performance, workforce, resilience plan, financial plan, and the MFIS plan. And she's also asking us to approve the budget for the CCG for the first half of the year, 6 months. So are we all happy to approve as recommended in the paper? Yes?
Yeah.
Yeah. Okay, you're away, Jane. That's it.
Thanks, Graham.
Thank you. Okay. Right, the integrated performance reports. I wonder if we could just have a brief overview of the providers, because all of the metrics are there, and some of them are nationally reported. I think we're more in the recovery stage, as Paul was just saying in the previous paper, weren't we, in terms of looking at the backlogs and things. So we could concentrate on that, I guess, a bit more.
Graham, I'm happy to just kick off, and then sort of some colleagues maybe want to come in some their part. I think you're absolutely right. If you look at on face value, this is month 12 report, so essentially March report, and times has moved on quite significantly since that report. And you could be forgiven for your eyes to be drawn to obviously the RTT, which is getting slightly worse at month 12. Slight improvement in terms of 2 weeks referrals, but again 62-day cancer performance underperforming as would have been expected given where we were in March. I think we do need to start looking at it through what is happening today. So if I can just give a bit of a summary really where I think we are today and what I think the expectations might be as we move forward. If we learned one thing through the initial phase 3 is that we saw that when we switched on activity and productivity, what we saw were cancer metrics improving. We saw some of the RTT improving, albeit we still saw some of our waiting list growing as a size of it. So again, you'll have seen from the planning guidance that there's an expectation that we need to meet certain level of activity. The honest and brutal answer to that is that that's not enough to recover our waiting list, because if you were simply to achieve that, our waiting list would still carry on growing and doesn't resolve the problem. So again, if you then go toward the ERF, which essentially incentivizes this system to actually do more, it's worth noting that as a provisional measures at the end of May, if you looked against the various pods, i.e. your inpatients, your day cases, your follow-ups, etc., we were in the upper 90% in terms of performance, so way significantly above what the planning expectations are. Big caveat to that, though, we have an issue with West Suffolk where there is to be some remedial work done to the theatres. So come the end of May, we will lose about 40 to 50% of our theatre capacity, and we need to compensate for some of that. So generally a really good position as we are now in terms of activity. The other point I would make is in terms of diagnostics. If you'll remember, we've got significant weights back in phase 3 on diagnostics. We've been able to maintain that through COVID. And I think I'm right to say that we're currently at about 7-week wait, which is phenomenal, particularly on MRI and CT scan, slightly more challenged than endoscopy and things. But actually, we've been able to maintain our diagnostic recovery throughout the third wave of pandemic. So again, some really good news story around some of that. that brings us into the accelerator site. And nationally, as you know, there was an offer to support systems in terms of accelerating some of our recovery. And that comes in a number of packages. Yes, some additional funding to support some transformation, but more importantly, some support from the national teams across a number of measures, whether it be infection control, new pathway redesign, productivity, waiting lists. Clearly, a lot of support from the national team as part of that program. So really pleased to say we were successful. We are working really hard to try and accelerate our sort of productivity, and we're doing that in a number of ways. Firstly, by switching on more capacity, Vanguard theatres, providing some greater work, development work on day case unit at West Suffolk, working harder with our sort of private providers in trying to switching on more capacity, and generally internally looking as to what we can do in terms of internal productivity. So that work is very much ongoing. So the target essentially for us is 100% by July, moving relatively quickly to about 120% of September, October. Looking where our trajectory, we sort of thereabout for the July target and currently moving on the 120%. Broadly teasing out our approach, there is a real opportunity for the Accelerate program to accelerate some of our digital work, and that piece is ongoing. Accelerating our workforce sort of support, and again that's ongoing. And importantly, reviewing some of our pathways. And while some of the pathways have been nationally mandated, such as eye care, I think cardiology and MSK, there is about 29 pathways we're supposed to be looking at, and we've engaged into an early extensive program to start doing some of that as we move forward in the forthcoming month. So again, real aspirations to actually switch on our capacity as we move forward. What I expect to see, and that's a personal view, is that if we get some of that right, we should start seeing some of our cancer improving, some of our RTT improving, and the growth of our waiting list slightly slowing down. So again, huge opportunity, huge amount of work that has to happen in partnership with the rest system, and that's the work we currently undertake as we speak at the moment. So for me, that's a constitutional standard and sort of where we are in broadly. My eyes are drawn to a couple of other things within the report, and some of my colleagues may wish to comment on that. Clearly, we've heard a lot of extensive work done around mental health. We heard about the PD work. We've heard about the eating disorder work this morning, and also clearly within all of that is a health and wellbeing hub, which we're working on for children, and we're clearly working on ADHD, adult attention deficit disorder, also as a priority as we move forward. So again, a huge amount of focus on performance and keeping our patients safe, if you want, in terms of coming out of the pandemic. And finally, which is something which is a bit different within the IPR report, is you've got a real summary of all the transformational programs that we are currently engaged, either now starting or continuing, which really underpins our performance as we move forward. So I think that's a bit of a quick whistle tour of sort of my take on the report, and happy to try and answer any question open to my colleagues.
No, thanks very much, Paul. That was really positive. You seem quite confident there in terms of the delivery of this. I suppose my only question, I suppose, is sort of staff fatigue in all this. We're asking them to sort of work at 120% of what they were doing, say, 18 months ago, and I think that's a big ask considering what all the staff have been through. So, but I mean, what you're doing, I mean, you're extremely positive, and I think you're right to have that positive frame of mind and.
If I may say, Graham, just a couple of things, and my colleagues will want to come in, but there is a reason why there are gateways in terms of the RF money, and that's partly the staffing and people board conversation, which Amanda can talk about. Clearly, within our accelerated bid, we put some contingency for workforce and what we might do differently. When we look to the Vanguard National Theatre capacity, we're looking to bring staffed theatre capacity, not just staffing it from scratch, although there are huge challenges around some of that. And clearly all organizations spoke to as part of this conversation are very, very focused on staffing issues and what that means to their staffing groups.
All right, okay, that's encouraging. Imran?
Thanks, Graham. Paul, with the accelerator sites initiative and support, are there any stings in the tail? I mean, if we don't achieve what we've been asked to do, is there any risks financially? I mean, reputationally, probably not, because they can be managed, but are there any system risks we need to be aware of?
I think in financial terms, we've been told there's no clawback. So actually, that I think that's answered that bit of the question. I think that there will be a really high level of scrutiny, and rightly so. I think around why didn't you get their question might well be what was the learning, which is very much part of the reporting we're expected to provide, because essentially what we are seen as is trailblazers in terms of the second half of the year, where I'm suspecting nationally all systems will be expected to step up. So for us, it was a real opportunity to try and get ahead of the curve in terms of our thinking and get the other additional national support that comes with it.
Brilliant. And also, I know you mentioned it before, but particularly around some of the elective recovery, it's not just about money into the acute trust, it's about the whole system, community, primary care, mental health, all of that. So that's really encouraging.
It is.
Yeah, thanks. Amanda, and then Pete.
Thank you, Chair. So just building on from what Paul said around the workforce element, I've been working closely with my colleagues in both provider organisations, and we're managing the acceleration programme through our SNE People Board. But in terms of additional workforce, we have identified the additional workforce that we require to deliver, but we're also looking at how we can transform the way we work as well. So it's a double-edged sword, but I think it's fair to say at this moment in time, we have a good grip of what the issues are. We're working in collaboration with ESNEFT in this particular case, and confident that we can deliver with the additional resource capacity that we've been given.
Great, thanks, Amanda. Peter?
Yeah, just kind of broad things. First of all, just to back up everything that Paul said, that I think, we're not there, but we're not in a relatively good place compared to where we could have been. And to answer Imran's point about the accelerator program, I think one of the reasons we got chosen as an accelerator site, because it actually builds on a lot of work we're already doing, particularly in terms of the BAGS programming, elective care, and explains what that acronym means somewhere in the papers. I can never remember. And the bit about workforce, I think that's allied to that, because there's always a risk of a burnt out workforce, but one of the things we're trying to do is actually not work more, but work innovatively, so the actual workload doesn't increase. And I think that's a really important point.
Yeah, no, that is, yeah. Okay. Lisa, any more questions for Paul, or should we move on to Lisa? Are you happy to come in next, Lisa?
Yeah, of course, definitely. Thank you. So I won't go through each provider, Graham, but I'll pull out, if it's okay, the two key quality risks that I would just like the board to be appraised of. So firstly, ESNEFT, so they're doing incredibly well with their infection prevention and control. Their COVID, as Ed said at the beginning of the meeting, zero COVID patients. They have really done some amazing work. A month ago, they were in a different situation, and they've really pulled that around. So congratulations to them. The area that we are working with ESNEFT on at the moment is in their maternity services. So they have had 4 external reviews now across their 2 sites of maternity services. So they are reviewed out. 2 of them they requested themselves, and one of them was done collaboratively between us, NHSEI, and co-produced with ESNEFT, and obviously they have had the CQC inspections on both sites. So I think it's absolutely fair to say that ESNEFT are very well cited on the issues that they have in maternity services. The reviews have pulled out very similar themes. And probably two of the main themes that are then causing some of the other issues that they are seeing is around their vacancy rate and their workforce. So particularly ESNEFT, obviously I oversee the maternity programme across the whole of Suffolk and North East Essex, but particularly ESNEFT and particularly the Ipswich site have had some real issues in recruiting midwives in particular. There have been other professions that they've also had some difficulties recruiting, but midwives is a concern. We did an LMNSB, a maternity and neonatal service board recruitment campaign. We developed a video. We did it as a system rather than as an individual provider, and we recently had a whole weekend of recruitment, which was really successful, particularly for West Suffolk and the Colchester site. Less successful on the Ipswich site. We did recruit a small number of midwives, but obviously as we've been quite successful in recruiting to the Colchester site, I'm sure the organisation will be able to work through any transition of workforce they need to do between Colchester and Ipswich to support their Ipswich site. The other area that there has been some real around has been in the midwifery leadership. So they have now successfully recruited a director of midwifery. Their previous director of midwifery retired recently, and the new director of midwifery will start with them in September, which feels like quite a long way away from May, but obviously can't be released from her employment before then. They have been out to advert for a head of midwifery for the Ipswich site, but unfortunately were unable to appoint during that recruitment. So as a system, we are supporting them. The regional chief midwife is supporting them. We have a great director of quality from NHSEI who lives locally, and she is a very senior midwife. She's offering a lot of support. And also my maternity board clinical midwife, Terry Gavin-Jones, is now based at Ipswich site 5 days a week to be able to provide some leadership capacity. So we are supporting them and trying to respond as a system, but there are some quality issues and workforce issues that ESNEF need to address within their maternity services. And you will see through the other papers this wherever continuity of care is mentioned through the transformation programmes or any of the other areas, it's flagging as red, and that is twofold really. One, when a clinical service is needing support, they turn to making sure that the services they offer are safe and clinically effective, and their ability to engage in transformation is decreases really. So they are making sure that they're going back to basics, if you like, making sure that women are getting safe, effective care, and some of the transformation work, which we know will deliver better care longer term, we've just had to put a pause on for the moment. So continuity of carer being one of those. The other thing that's impacting on the rollout of continuity of carer is the vacancy rate. So ESNEF successfully agreed a business case for additional midwives to get them to birth rate plus. But obviously, we've got to get those midwives employed before we can start delivering continuity of carer. And the director of nursing is very supportive and is really keen, particularly in the tendering area, the coastal area, where there is some real need for a continuity of care approach to prioritise those areas. So we're just continuing to work with them. So that is probably one of my areas of concern. I think just turning to the other provider, which is NSFT. So again, to start with some real positives, we've seen some amazing work. I visited their LD inpatient area last week, and you'll remember that the CQC highlighted the LD inpatient area as not being safe and requiring some significant change. They have now completed that change, and it looks amazing. Patients are really experiencing a much better environment, and their staffing and their models of care have been much improved over the last year. So we're really grateful for that. they've seen a real increase in acuity in their inpatient areas, and they are as well managing that really well. That's been incredibly challenging for them to be able to continue to deliver the services that they need to deliver in their inpatient areas with such high acuity. The areas that the area Paul's already mentioned that we are putting significant focus on, two areas in particular that both sit within our children and young people services. One is eating disorders, and we've already heard the recovery plan for eating disorders, so I won't go into that further. And also, as Paul said, the wellbeing hub. So I think the paper, our report says that there are 1,700 children on the waiting list. It kind of fluctuates between 1,700 and 2,000. By far the majority of those, normally around 1,600 of those, sit on what's called their green waiting list, which is the less acute need. They also have a red and an amber, and we typically see around 100 children waiting on their amber list. So they have seen significant increase in referrals. I chair a weekly emotional wellbeing hub recovery meeting, which gets a weekly report from the Task and Finish group. It's a multi-agency group, and that's very much focusing on the demand and capacity. So we are looking to reduce the demand by supporting people to access the right service at the very beginning. So we know a number of the children that are currently waiting for a response from the Emotional Wellbeing Hub could have actually sought support from their school nurses or health visitors as the first point of call. So we're just doing some work to understand how we can make sure children and young people access the right services at the right time. And the second piece, obviously, is about building capacity within the team. So in the short term, there's been a collective system response from NSFT, CCG and Suffolk County Council to increase staff in the Wellbeing Hub. It has got to a slow start, if I'm honest. We've had to resolve a number of IT issues, training issues, making sure that all the staff understand the pathways so that they are safe to be having conversations with children, young people and their families. But that has seen some benefits. Some of the issues that we are now having to respond to is as children are referred onwards from the Emotional Wellbeing Hub, is we are realising that other services are also, it's creating capacity issues in other services. So we're needing to look at the other end. And we've just agreed last Friday a number of schemes to support the increased capacity in the hub and additional staffing, and also additional support to children and young people that sit on those waiting lists to make sure that they are getting any support that we can give them prior to accessing the right service. So I think they were the only two areas that I wanted to flag, Graham. Thank you.
Thanks. Are there any questions for Lisa? No, I think we're okay. Just Eugene, could you come next and talk about the transformation work just briefly?
Yes, thank you, Chair. I think Paul has touched on it in terms of his summary. The team have worked to refresh the transformation programme over 21-22, and the papers include the charters from mental health and LD, integrated care, our pan Suffolk and North East Essex projects like cancer and respiratory. I think it's fair to say that we're increasingly moving into the conversation about place versus strategic programs of work. So you'll see in those charters by theme, taking mental health, for example, where we've tried to identify in blue, whereas there's that absolute direct crossover to have to do things in Ipswich and East Suffolk, and in West Suffolk and in North East Essex as we go. So that conversation, the governance that we've currently got in place, we've got mental health governance specifically, which looks at very more purist mental health conversations, but we're going to have to blur that and look very closely at how we work with Maddie and the team and bringing that alliance conversation into that mental health space. So particularly with dementia, older people, frailty, and the new community mental health model, and working with our integrated neighbourhood team. So very exciting, but quite a complex space in terms of the number of stakeholders that there are working there. But I think just to say that the programme of work is there. We've got the key projects pinned down and the project leads. So we think we're in a good place now going into 21-22.
Great. Thanks very much, Eugene. Any questions, Paul?
Yeah, just to build on what Eugene just said, there's just been a consultation around what they're calling system oversight framework, which is essentially how, system will be overseen, should we say, or performance managed, for want of a better word. And what it starts to do, the draft version, starts to try to articulate the relationship between system and place. So everything Eugene has said is absolutely right. There'll be a greater emphasis on place and some clarity about who gets held to account where and how. So again, watch that space, but I expect to see the document come through the next month or so. Great, thanks.
It's all positive stuff, isn't it? And you can definitely get a feeling from the meeting that certainly, working much more closer with our partners is all starting to become sort of just a business as usual theme for us, isn't it? That's what's coming through strongly for me anyway. So, okay, if there's no questions for Eugene, thanks for that, Eugene. Maddie, you're next on the list of papers.
Thank you. So there's a very brief report here in terms of primary care. As everybody knows, the metrics in terms of referrals to secondary care are a little artificial at this time, so it's probably not the key piece to focus on. There's a great deal of work going on to increase our dementia diagnosis, to undertake the LD health checks as discussed earlier, and also SMI health checks. So the data here is a little out of date. I'm pleased to report there is a slightly improved position on that pack. Just to say, the other thing is in terms of prescribing, as we know throughout the COVID period, the prescribing costs did go up. Some of that relates to actual costs, and some of that relates to volume, and some of it relates to increases in primary care prescribing in lieu of secondary care prescribing. So we have a great deal of work to do now to understand that position and to work. And I think we'll be working increasingly with our colleagues in West Suffolk to understand what we can collectively do to address. So that's just the main elements. I would just say there's a short note there in terms of the primary care transformation and the development of PCNs, and that is progressing well. People are working together incredibly well in the challenging circumstances and continue to do so. And there is now growing recruitment into the roles supported through the ARRS, the Additional Roles Reimbursement Scheme. Got it. Yes. So it is primary care continues to be open and serving local communities. It is incredibly busy, I think, as people have started after vaccination to increasingly come forward, potentially with issues that have been there a while. So primary care colleagues may wish to expand further, but that's the overall position, that there's vaccination and business as usual and transformation going on. So it's an absolute 3-in-1 job at the moment. Thank you.
Thanks. Any questions for Maddie? No, Jane?
Yeah, thank you. And we're on to the finance report, which comes on page 51 of your pack. But what we're reporting is the position at the end of the financial year. So as at 31st of March, just passed, and I'm pleased to report that the CCG has reported overall a balanced position for the year, which is really positive news. Within that, we were given resources for COVID to deal with the extra costs both within the CCG but also with our partners in social care around the hospital discharge programme. And you'll see in the reports that we spent around 26 million of additional resources on COVID, the largest elements being the hospital discharge programme, about 20.5 million of that as shown in the detailed analysis, but with further amounts for areas described as remote management of patients and aftercare and support costs, as well as enhanced patient transport and various other things, as you can see in the report. So we're obviously in the middle of the audit of the position for the year, which we'll be reporting back to the governing body in due course. But assuming that nothing significant comes out of that, we will hopefully finish our financial year as in that overall balanced financial position.
Thanks. Any questions for Jane? No? Okay, move on to the next item. Thanks very much, everybody, for their contributions there. Governing body framework. I've got really nothing to add to that, to be honest. It is a working document, isn't it, that you look at and use every day or week. The key points are in paragraph 2, and the departmental risk registers are listed at the back. I've got nothing more to say. Do any of the risk holders want to add anything to the paper, or we can just go ahead and nod it? We'll just nod it through. Yeah, okay, thanks very much. And then Amanda on the terms of reference.
Thank you, Chair. So our terms of reference for our remuneration and HR committee have been recently updated to reflect the fact that we've now adopted the model constitution as of the 1st of April. The terms of reference have been through the last REMCOM a couple of months ago, and the changes are shown in red for ease of reference. But I basically commend the updated terms of reference to a governing body this morning. Thank you, Chair.
Are we happy with those? Yes, that's fine. Thanks. Thanks very much, Amanda. Health and safety.
Thank you very much, Chair. So this is our standard report, which reflects the fact that we continue to meet albeit twice a year. We last met as a committee at the end of April, and the key points of discussion are shown in section 3. And it won't be a surprise to hear that we continue to make sure that our workplaces are COVID secure in terms of making sure that when folk do come back to work, they are coming back to a safe environment. So we have risk assessments continually updated and shared with our staff. And we talk about sickness absence, which is again reflected in the report, and we just confirmed our annual plan and focus for the year ahead. So nothing untoward, Chair, a very typical business meeting, but again, happy to take questions.
Okay. Just following on from what you said, Amanda, when do you think that we'll get back to the office?
Good question, Chair. I mean, we have never stopped our staff from returning, and we have always had folk returning if they need to go into the office with, appropriate places in measures in place. I think we are watching with interest, but we are having regular conversations as a directed team in making sure that we have provision, that we have social distancing, that we continue to operate safely. So I think in the coming weeks, the landscape will be clearer, but we are supporting our staff, as I said, to return as they need to.
Yeah,
I think it will be a gradual.
Yeah, because I think, when you walk into the office, the first thing you see is everyone's quite jammed up closely, aren't they? And
Indeed.
I think there'll be a bit of trepidation amongst the staff in terms of coming back and
absolutely,
safety.
But we are working with our staff through the Organisational Development Group, Chair, and we are working with them and reflecting their ideas on what they would like to be put in place prior to any return, just to make sure that everybody feels safe and that we as an employer are fulfilling our responsibilities as well.
Yeah, okay. Any other questions for Amanda on health and safety? No? Okay, thanks very much. Amanda, the declarations of interest.
Thank you very much, Chair. So again, our standard report that reflects all of our declarations of interest, and it would be good to hear from members of the governing body if there are things that we are not doing that we should do to reflect and improve performance going forward. But I think we, work closely with Maddie and her colleagues to make sure that we get returns submitted in a timely way. But it's here for our information. But again, happy to take any questions.
None? No? Okay, thanks, Amanda. We'll note that paper. And then minutes of the meeting. I've got nothing to add to that. Unless there's any questions from any of the meeting notes. No? Okay. So the date of the next meeting is the 27th of July, 9 till 1 o'clock. And then we'll go on to questions from the public. And Simon, can I bring Simon in here?
Thanks very much indeed, Graham. We've got a number of questions that are coming today and also before the meeting as well. A series of questions from Anthony Dooley to start with. His first question is, what is the attitude of the CCG to the award of contracts to run GP surgeries in parts of London by Centene, and if Centene or any other private provider sought to be awarded such contracts in the area covered by the CCG, what would be the CCG's response?
Maddie, could I ask you to?
Yes, thank you. So in all of our primary care contracting, we are duty bound to follow the national policies and procedures, and that's what we would do in any such scenario in Ipswich and East Suffolk. So I think that's all that I can say, that we would be required to follow NHS England policies and processes.
Yeah. Okay, thank you.
Thank you. The second question, at some point we understand, Anthony Dooley writes, all CCGs in England will be morphed into an integrated care system. What will the implications of that change as far as your CCG is concerned? We are thinking about changes that could include private providers being involved in making commissioning decisions about changes to the current arrangements for accountability to the public and how the ICS system will function, given that the promise on the plan for the future of social care made by Johnson in 2019 doesn't exist.
Ed, can I bring you?
Yeah, of course. So, I mean, I would point Mr. Dooley and other interested people to Maddie's paper on the alliance plan, because that's the direction we're heading in Ipswich and East Suffolk, which is bringing together local providers to get better outcomes for the population. So what we're looking to do is to collaborate more with existing providers, and which is at a place level, which is exactly in line with the white paper, if not being ahead of it. So I would welcome it, because this has been an ambition and a piece of work we've had underway for many years locally.
Yeah, thank you.
Thanks, Ed. The third question for Mr. Dooley. Do you welcome the decision by the devolved government in Wales to introduce a pilot universal basic income scheme to address issues of income deprivation as it impacts on other inequalities such as health?
Ed, I'm going to ask you to come in on that as well, Ed, if you don't mind. But the only thing is, I'm not certain this question relates to the agenda in terms of what they're doing in Wales. But I mean, you can answer it any way you see fit, I suppose.
Yeah, I mean, it's not directly relevant to the agenda, but I would think that any government scheme that's supporting our most deprived communities should be welcome. So I don't know about what they're doing in Wales in any depth, but in principle, it sounds like a positive move.
Yeah. Okay. Thanks very much.
Fourth question from Anthony Dooley. Can the CCG/ICS provide an update on how the implementation of the local ICS is proceeding and how it compares with the previous CCG structure? And if there are future changes, what are you anticipating those to be?
You may have already answered this.
I think so. We're progressing our alliance in Ipswich and East Suffolk is the big local development.
Yeah, thanks.
Fifth question, I would like to ask Richard Watson on behalf of the CCG about the introduction of what is known nationally as SIM, but locally is referred to as JED. What involvement was there of the CCG as Commissioners of Mental Health Services in its introduction? It appears additionally from the report provided that those with eating disorders are not at the moment having their needs met. Why not? Also, why is the 24/7 mental health crisis support model within Suffolk for this year RAG rated as red?
Eugene, thank you. You answered it.
Yeah, happy to take that, Chair. So the CCG was part of the working group that develops the joint engagement team, the JET team, alongside Suffolk Constabulary and NSFT at the time. The 2-year pilot is now under review, and there's been a number of sessions held over recent weeks, with the next one tomorrow, with partners to seek views and listen, and to seek how we proceed with the scheme in the longer term. The eating disorder service nationally, as we heard earlier on the agenda, is under significant demand, and we're therefore unable to meet the demand of all individuals who are presenting in terms of meeting our national access targets. The ED business case phase 1 has therefore brought forward our plans in an attempt to bolster and support our local services at a time of need. The 24/7 mental health crisis support is red rated in our RAG rating in terms of the delays due to COVID of implementing our crisis cafe plans in East and West Suffolk as part of our alternative to admission. They are now a top priority for us, and we're looking to move forward those plans as quickly as we possibly can. Thank you, Chair.
Great, thanks very much.
Thanks, Eugene. There's the sixth question here. Given the rightful positive response to the introduction of a single midwife to be assigned to expectant mothers, why is the target for that RAG rated red?
We know where this is going.
Lisa, I think.
So I think I probably covered this when I did my update on maternity, but it's RAG rated red because we've had to pause the rollout, unfortunately, in ESNEFT due to the concerns that I updated when I did my maternity update. And I'm thrilled that Anthony is really interested in the rollout of continuity of care, and you know, we are committed as soon as we can to continue rolling that programme out.
Great, thank you.
Hey, thanks, Lisa. There's a few more questions here from Anthony Dooley. Received today. These are they. Do you agree that the decision to lift the requirement to wear masks in schools was premature, given data about school cases of B.1.617.2, particularly given cases linked to Bolton in Needham Market?
Ed,
I think that's a question for the government to answer. I don't think we're in a position to. We might have a private view, but we're not in the position as a governing body to give an official response.
Yeah. We certainly not discussed that and agreed it as a policy for the CCG, have we? And it's probably the county council anyway, if it's main schooling.
Okay, the next question from Anthony Dooley. By 18 years of age, 1 in 13 will have experienced PTSD, and only 1 in 5 will have seen a mental health professional in the past year. What will the CCG commit to address this other gap in provision locally?
Or Eugene, mental health?
I think as our ongoing work of transformation and our system-wide response, where we'll be looking at our needs assessment and addressing every mental health need that comes through. So we'll take every input we can into those conversations.
The final question from Anthony Dooley before we go on to one from Mr. Squirrel. This is the final question then. Will every young person from now on who presents with any mental health issue not be turned away because they're not ill enough?
Yes. Eugene?
Again, the response that, as we've talked about throughout the meeting, in terms of the wellbeing hub and everything that we're doing in terms of bolstering school support for mental health, we're trying to have an early intervention and prevention approach so that we're supporting everyone who's presenting with all needs, and that will continue to be the case.
Yeah, thank you.
And we have one last question now. This time it comes from Mr. Squirrel. And it is as follows. If you wish to address staff retention and morale, I suggest you provide adequate parking for your staff, including those that live within the 3-mile exclusion zone. I am concerned for the well-being of staff at Ipswich Hospital. I believe that the staff parking policy affects far more women than men, and this after all their hard work during COVID. If you make the workplace a hostile environment, people will leave. It has been all over the news how unsafe women feel on their own, especially after that recent murder. A 3-mile walk takes 45 minutes, a 3-mile drive takes 6 minutes, a bus takes 20 minutes if it's running to time and fits around your 12-hour shift. Weekend bus services are even less frequent. This is ludicrous. Surely it shouldn't matter how close the staff live to the hospital. This clearly demonstrates the lack of both foresight and hindsight, as this will mostly affect women. 12-hour shifts and then walking home in the dark. That's his question there.
Ed, I don't know who's best.
Yeah, I mean, it's an important point that Mr. School raises. I think what we can do is share that with ESNF, with Ipswich Hospital, and ask them for a response.
Yeah,
thank you. Those are all the questions.
Great. Okay, well, that's good. Thanks very much. Okay, if there's no more questions, so nothing came through on the chat function, Simon?
We included those from the chat function, so they're all included. Thank you.
That's great, lovely. Thanks very much. Then I think that is the end of the meeting. And unless there's any more, we'll make it a close then. Yes. All right. Thanks everyone for your contributions. We need to click out of this one and click straight into the private meeting on a separate link, don't we?